Good morning, everyone. Good morning. If we could get everyone to take their seats, please. We are a couple of minutes late getting started. It's Tim Bearden's fault. If everyone would please come on and take your seats. We've got a lot to cover today, and it's going to take a while to get through it. And I'm going to ask our presenters as we get started this morning to please adhere to the times we have on the schedule. And I would ask members of the committee as they come in to be mindful of the schedule as well as they're asking questions. We do have a lot of ground to cover, as I said a minute ago, and it's a very passionate issue by many of those that are presenting and by many of us sitting around this table, something that a lot of us have a lot of interest in. And so I'd just remind everybody to control your tempers, control your emotions, control your passion, because this is nationally broadcast. We're not to pay-per-view status yet, but we may be after today. Our first presenter this morning is a lady that I've come to know and respect an awful lot. Patsy Whaley is the director of DCH's Office of Rural Health. Patsy has been working with us now several years on the Rural Hospital Stabilization Committee, and also the Office of Rural Health is the one that is charged with coming up with the RFP for the Rural Health Center as well, that all hospital board members will be going through required training and everything through. So Patsy's going to give us a little bit of an update on that and some of the work of the Rural Hospital Stabilization Committee this morning to start us off. So, Ms. Patsy, the microphone is yours.
Good morning. Members of the committee, Chairman England, good morning from the State Office of Rural Health. I'm going to give you a short update on the status of the Rural Hospital Innovation Request for Proposals, as well as a few comments on the Rural Hospital Stabilization Program and the Tax Credit Program. Following the state's procurement policy, DCH is currently in discussion regarding the criteria to be included in the RFP. The timeline established for posting the RFP is mid-October. A meeting is scheduled at DCH the first week of October to ensure that the work is done and that the RFP is completed on time. Rural Hospital Stabilization. A sincere thank you to Governor Deal, all of you, regarding the generous funding of $12 million for the Rural Hospital Stabilization Program. As of June 30th, 18 hospitals have participated in phases 1, 2, and 3 of the program. In July, 4 additional hospitals, Burke, Clinch, Elbert, and Evans, have initiated work in phase 4. Stabilization projects have addressed the reduction of non-emergency visits to the emergency departments. They have also addressed the reduction in readmissions within 30 days, behavioral health, increased access to primary care, telemedicine, care coordination, new service lines, and many other projects and programs that have positively impacted local health care and the local economy. It is the hope of rural that this program continues for years to come. Their healthcare partners and hospitals have the opportunity to preserve local health care for the communities that they serve. While I can communicate the impact of the program, there's nothing like hearing it from the hospitals themselves. The annual Rural Hospital Stabilization Committee annual meeting will be held November 1st in Macon at the Public Health Center at River's Edge. If it works within your schedule, you are cordially invited and encouraged to attend this year's meeting to hear the results of this outstanding program. Tax credit program. 58 extremely appreciative hospitals qualify for the tax program. Not only does the program assist in maintaining local health care, it has provided the long-delayed opportunity to replace outdated equipment, address long-term debt, indigent and uncompensated care, essential renovations, provider recruitment, and many other critical needs. In conversations with many of the qualifying hospitals, they have expressed their appreciation to the General Assembly and Governor Deal for recognizing their struggles and providing the means to help them survive and succeed. We at DCH and at the State Office of Rural Health established this year's timeline for submission of the required hospital documents, reporting contributions, and filing the annual report to the legislature. These documents, the timeline, and list of qualifying hospitals is posted on the DCH website, and we are always available to assist in any way we can. Thank you for inviting me to speak with you this morning.
Okay, questions? Patsy, I got a couple on the hospital tax credit program, or one, I guess. Do you know of anything that we need to do to kind of come in and maybe touch it up a little bit on looking at qualifications, looking at what the dollars can actually be used for? We've heard a few anecdotal stories about some things that are being done with some of that money. Do you feel like that there's an opportunity to kind of tighten it up a little bit, I guess, is for lack of a better word, to make sure that it is actually going to health care, paying down debt, renewing equipment, renewing facilities?
Based on the reports from last year, Chairman England, I haven't recognized any use of those funds that deviate at all from the submitted 5-year plans, of course, that all hospitals are required to submit. I won't know about the use of funds for this year until the hospitals report to us in January.
Okay.
So there's not anything that I can really respond to regarding that at this time.
If you don't mind, when you look at those in January, if you do see something that kind of pops its head up that you feel is kind of out of line, if you don't mind, let myself or Chairman Powell know.
Be glad to.
Because we want to make sure number one, that works. Number two, that the dollars are being used for what it's supposed to be used for. And number three, that it's something that as it sunsets, that we were able to redo or re-extend for more years, because we do realize that those hospitals that are participating the dollars are helping them an awful lot in many ways, and we understand that. We just don't want someone maybe to do something that puts the whole program in jeopardy, one bad actor doing something that endangers the program for the rest of those participating. On the timeline on the center, can you go back through that again? You said a meeting at 1st of October, but the RFP is posted.
The RFP is scheduled for posting mid-October. There will be a meeting the first week in October at DCH to make sure that the work is done and that the RFP is posted on time.
Okay. Okay. Clay?
I think those around the table will have recognized and have said publicly that one of the best bills that we have passed, a great bill, is that the rural hospital tax credit. It has been the lifeblood for some of our sickest hospitals. In looking at the numbers, could you see a fairly equal distribution across the hospitals, or did any of the really sick, the hospitals that were eligible and were participating that did not receive a decent share? Because I know I don't know what you call the subscription, so it filled out pretty doggone quick this go around.
Well, at this point, with these contributions, we won't have that information until January.
Okay.
Just what those contributions have been, what the distribution has been. And thinking back of last year's contributions, there were contributions from a low of about $5,000 to a high of $850,000. So there was a spread between those two amounts of contributions. So we will know in January what those contributions are for this year.
Okay. Rick?
Yes, ma'am. Thank you, ma'am. Following up really what you're talking about, Representative Perkle, can you tell the committee, how and who decides the placement of that? Like you said, 850,000 to, I forget the low number. Of course, I remember the high one. How that's done, who does it? I'm just curious on how that works.
I'm not real sure about who decides where. The best information that I have is that the taxpayer who is donating the funds has the option to choose the hospital that their contributions go to. If they reach their cap, I'm not sure at that point what happens to those contributions and who makes the decision about where they go.
Does a board determine this, or does if someone doesn't designate, it goes into a pool, and then assume someone evaluates who needs it the most?
I don't have that information. I can certainly look into it and get back to you on that.
Yes, ma'am. I'd love to know.
Okay.
Thank you.
And Rick, I would tell you that that has been one thing that we do know already that needs to be tightened up a little bit on the application process through DOR, not necessarily through Patsy's shop, but there is an organization that is getting hospitals to subscribe to a service, and did find out during tax season after the fact, when it was too late, that individuals had the opportunity to choose a hospital to send to, or if they did not designate, they could check a box that the organization would then choose where those contributions went to.
Yes, sir.
So we do need to tighten that up. DOR was unaware of that. It happened to be my CPA when we were talking about the program. I'd asked a question about it, and he said, well, I had some people wanted to give to certain ones, and then several of them told me just to pick, and then I just got tired of picking, so I just went to the box to let this organization decide. That has never been the intent. The intention has always been that the individuals choose which hospital it goes to.
Okay.
So we do know that that's one issue that has to be tightened up.
Thank you.
Other questions? Well, all right, Ms. Patsy, thank you so much.
Thank you.
Our next presenter is, for those of us that have been in the house for a little while, he needs no introduction, but the way he is slicked up today, he may catch a few by surprise. Jesse Wethington is with Total Spectrum, Steve Gordon and Associates, but we better know Jesse from working in the House Budget Office and working at DCH for a while as well. And so Jesse, we'd ask him to come and kind of set the stage of discussion this morning, as we're going to hear a lot of folks for and against CON. And Jesse has probably dealt with this as much as anyone that I know of. And so we've asked him to come and give us a presentation this morning as well. So Jesse, the floor is yours. Thank you for being with us.
Thank you, Chairman England, Chairman Powell, members of the council. I'll go ahead and apologize for my voice. I either have the the daycare crud or seasonal allergies or other, but I'll try to work through it, so excuse that, and I've got my cough drops and water ready to go. So appreciate the introduction. Representative England, as you stated, I came to this, working on this issue back in 2005 as a policy intern. My boss came into my office, or rather I got called into my boss's office, and they said, have you ever heard of certificate of need? And I said, no, what's that? Working on the special committee of certificate of need in the House, my first round as a House employee, and then moving over to the Department of Community Health to look at the regulator side, coming back to the budget office for a couple of years to work with y'all, and then the last few as a private advocate, largely in the healthcare industry. Had a chance to look at this issue from a couple of different angles, and that being said, I am here today at the invitation of the council, as you stated, not here on behalf of any client. My opinions are my own. So with that, I'd like to move into the balance. Brent, do I do this over here? I can't get it there. There we go. Exit it. So I wanted to start with a prompt because I think this is certainly timely work. Some of you may have seen this that follow healthcare as a matter of your everyday business. So a quote from the Secretary of Health and Human Services, Alex Azar, delivered to the American Legislative Exchange Council in New Orleans a few weeks ago. And pretty direct and unvarnished opinion here, we think, from the Secretary in terms of certificate of need regulations. Too often they can be a significant barrier to new market entry and competition, and to prevent the entry of low-cost market disruptors. And oftentimes in American healthcare, the answer is that government rules are standing in the way of necessary innovation. And we undertake efforts to free up competition. We would urge the states to look at this as well. So we certainly think that this is timely in terms of the remarks from the Secretary. So a little bit of a CON timeline. Rachel King did a great job running through this yesterday for you all. And so you've heard that this was something that originated in New York State in 1964 as a result to the fallout from the Hill-Burton Act and the completion of a lot of government-funded local hospitals around the country. The Medicare and Medicaid Act were passed, of course, in 1966 and 67. Certificate of need was really ramped up at the federal level as a response to control out of control healthcare inflation. Initially, the Medicare and Medicaid programs reimbursed hospitals on a cost-plus basis. That quickly became unsustainable from a federal fiscal perspective, and they started to, at various times over the past history of the 50-year program, institute various cost control measures. CON was initially characterized as a cost control measure, and then you have the creation of the DRG reimbursements, prospective reimbursements, HMOs, value-based purchasing. All of those have been attempts to rein in healthcare cost inflation since the government has stepped in and taken a large responsibility for the financing of the program. Of course, you all worked, there are several of you here who were present in the legislature at the time, working on Senate Bill 433. I think that Madam Chair Cooper is still the record for the longest hearing on any single bill in the General Assembly. That took a blue ribbon commission a couple of years to look at, and then it took the legislature a couple more years to mull the issue over. As you heard yesterday, and for those of you who have the scars from the last couple of CON rounds, you can get bogged down in the details of this issue very, very quickly. I'm not going to get into the relative merits of the boundary of a state service delivery region for perinatal care, but what I want to do today is try to give you a prompt to look at CON from a 50,000-foot level and evaluate it using some policy evaluation tools that we've picked up over the years. Some of you who have done the Legislative Health Policy Certificate Program will recognize some of those. But what has really happened since the last time you looked at Certificate of Need in 2008? There hasn't been any legislation that passed on this with the exception of repealing the Health Strategies Advisory Council in the 2010 or 2012 session, I believe that was, sometime in that time period. So since 2008, what has changed? Quite a bit. So the Affordable Care Act was passed and adopted, survived its Supreme Court challenges of various stripes, and has begun to become the law of the land, so to speak. Attempts to repeal have faltered at the federal level. So for the time being, we're stuck with an environment where the Patient Protection and Affordable Care Act is the law of the land. What has the result of that been? It has had a dramatic reduction in the number of uninsured, although Georgia still does have one of the nation's highest rates of uninsured individuals. Additionally, one of the results of the incentive structure in the Affordable Care Act has driven market consolidation among provider groups, as well as there's been lots of technological disruption. That's something that's a constant in healthcare. And so the environment is fairly different in terms of the healthcare landscape than the last time you all examined this as a legislature. And so today, as you've heard, we have a fairly restrictive program. We're in somewhat of the middle of the road in terms of regulating 17, really 14, as you heard from Rachel yesterday's services, with a number of exemptions and the letters of non-reviewability in terms of the capital expenditure thresholds, equipment purchase thresholds that she described to you. This map is a little out of date. This is an NCSL map from 2016 that does not reflect Indiana's change in CON laws this year. And as my friend Jeremy Betts pointed out to me yesterday, Louisiana has never had a program, but they're colored in on this map. So apologies for the oversight there. And you're going to hear a little bit more about this later, I think, from some of the other speakers. So I'll go ahead and move on. Yes, sir. Can do. This, as you saw yesterday, is the CON matrix that is published by the American Health Planning Association. You saw this, and I know that you can't read it. The resolution is a little lacking. But this shows you the states that have certificate of need programs, what services are covered under their CON statutes, and then you have the capital expenditure thresholds or thresholds for reviewability or non-reviewability over onto the right-hand side. I know that we've provided the council with this at a previous juncture, and this is an important document in terms of as you evaluate what to do about certificate of need, if anything. This is about as good a guide as you can get, quick and ready, to look at and make comparisons with some of your other states as you examine the ramifications of it. You know, the discussion has really been about hospital CON. The last time you looked at this in 2008, there was more of a discussion around imaging, general surgery, things of that nature. If you're looking at hospital CON, there's a whole host of other services that are covered under this that, you know, are not as controversial, certainly. So you may want to look at, if you're tweaking the statute, this would be a good way to look and make a comparison with other states in terms of, are we an outlier in regulating a particular service versus others? So in terms of a policy evaluation framework, the most generally accepted one in healthcare, of course, you heard, is cost, quality, and access. So Rachel referred to that as the three legs of the stool. It's also called the iron triangle or the trade-off triangle. And conceptually, what you see in this diagram is that typically in healthcare you have a Sophie's choice in terms of if you are moving towards increasing one goal in the healthcare trade-off triangle, you will typically have to make trade-offs or sacrifices in other goals. For example, increasing quality can have a negative impact on cost by having a less affordable, higher quality service. Access tends to cost money, so you will have an increase in cost. Decreasing cost can have a deleterious effect on quality, and so on. This is not totally ironclad. There are certainly virtuous examples of a policy option that can make positive gains on all three. But typically, conceptually, in healthcare, you're going to have to make some sacrifices in terms of one element or the other to get the gains that you're trying to capture in the particular policy goal that you're trying to move towards. It seems that the consensus from the comments in the council so far have been that rural access seems to be the first priority, and then quality and cost may be secondary, although you certainly can't ignore those things because, as you all understand from your work in the budget, healthcare costs can get out of control fairly quickly. Also, you are at the stage in the policy evaluation process where you're on the back end. This is an existing statute that's been on the books for many years, is familiar to most everyone in the healthcare policy arena. And so you're in evaluation stage. So you need to, at this point, be asking questions like, is the statute having the intended goal that it was originally enacted to achieve? Are there unintended consequences? Are those good? Are they bad? What is the effect of the law? And so as you're thinking about this, try to, again, get out of the weeds, because this is a real easy issue to get into the weeds on, and look at it from a strategic view and say, if this was not on the books, is this a law that we would pass today? What would be different about a new CON statute if you were looking at this fresh as a new policy proposal? Go back, Brent, if you want. Does the policy serve the goals that it was intended to achieve? And is CON the best, least distortionary means to achieve the goal that you have set out for yourself? So the title of my presentation is The Pros and Cons of CON. I thought that was apt because the first foray that I had into this issue was a white paper called The Pros and Cons of CON that I drafted way back in 2005 when I started to get familiar with this issue, and then got fairly well pigeonholed into healthcare policy as a result. So the quote that you see up there is from the North Carolina Department of Health and Human Services. You saw the justification in the Georgia statute that Rachel King had highlighted in her presentation yesterday. Typically evolves around cost containment is the rationale stated for the passage of these laws, at least initially, and that is accomplished by avoiding the unnecessary duplication of services. Therefore, you have to prove a need for your service in a generalized area and go through a process that's public and allows your other interested parties and stakeholders or perhaps competitors to weigh in on the process and demonstrate that the need is really there. That is described as a result of something that is particular to healthcare called the Romer effect, which you may have heard of. You have definitely heard it described in the context of the healthcare industry in that supply can drive utilization. Therefore, if you control supply, you can keep a cap on cost growth by having a natural break on utilization. Or the capital cost of a unnecessary service could potentially be passed on to consumers, insurance companies, or the government. Therefore, we don't want to have unnecessary capital expenditures above and beyond what the need would show. So that tends to be the rationale that you've seen for the statutes as they've been implemented. So how does CON measure up in the different corners of the healthcare iron triangle? So that's what I would like to take you through next. So in terms of cost, CON's cost control effectiveness is probably the most easy and consensus point of consensus around the effects of CON as far as cost, quality, and access. It doesn't really have a impact on controlling costs. The evidence is fairly clear there. The Department of Justice, Federal Trade Commission, numerous studies, evaluations of state programs have shown that it has not really had an effect of breaking or decreasing healthcare inflation. As you know, every year since 1966 or 1967, healthcare inflation has outpaced general consumer price increases, I think with the exception of 2010 or 11 due to the lagging effects of the recession. And to be fair, people are not really making the argument that CON does control cost. We have gotten into a situation where the law is on the books. There are going to be people who are affected by it, and dealing with the downstream impact of changing it is going to be what the fallout that you would all have to deal with if you decide to do anything about certificate of need. But cost containment is not one of the benefits of the program. Keeping competition at a minimum or only between incumbent firms, as you know, can have a negative impact on cost or people's ability to bargain or negotiate discounts as a group. So next, on quality, this is more of a mixed bag. I think you're going to hear about this a little bit later from some other presenters who are a lot smarter than I am and have done some more in-the-weeds work on this. But there is some evidence that suggests that by, especially for complex and high acuity procedures or patients, for example, some forms of invasive surgery, that limiting the number of surgical teams that are providing that service can actually have an increase in quality. You can describe this as the focus factory model. If you do one thing many times exceptionally well, you're going to tend to be better at it. However, there is some new evidence that I have seen that has come out recently that has shown that it may be more of a wash in terms of quality. And then, you have to ask yourself, do you really have access to quality health care if you have a world-class facility that is, 3-4 hours away, you can't get to it, and it's not, in your community where you live? Again, so that's part of the trade-off. You can have a high-quality service, but maybe with less access to it. The capital expenditure thresholds also have a distortionary effect, or the reviewability thresholds, equipment purchases. For example, and we heard this in 2008 many times, the CON Buster MRI machine, where it is just deliberately priced at below the cap so you can get in with an LNR. Now, that might not be the machine that you wanted to purchase, but it's the machine that you can purchase and put into operation. Therefore, the caps would have a distortionary effect on your decision to make that capital expenditure purchase, and you may get a less high-quality imaging device than you otherwise would have purchased. So, access. CON serves as a barrier to access in terms of entrance for new firms. It can amount to what amounts to an expensive delaying tactic. If you're persistent enough, you can certainly get through the CON process. You can find a way to escape reviewability. I think we heard the longest anyone in Georgia had contested a certificate of need was 14 years in Greene County, I believe that was. Madam Chair, am I remembering that correctly? It was a therapy service center, and it had been challenged for 14 years. It's one of the reasons why in 2008 the statute change that you all made put more specific time limits into the CON review process that the department has to complete review, but then, as Rachel described for you yesterday, that's certainly something that can go to Superior Court, and then the legal system has its own timeline. And access for rural patients has been impaired even with certificate of need being in place. I think that that's self-evident from the work of this council and why you're all here today. CON has not provided access that's adequate for rural Georgia, and that is what we're contending with. Innovation, disruption, and capital investment are impaired by CON because of the barriers to entry that it represents and the time, expense, and delay that one would have to take in order to become a market participant in a CON state versus a non-CON state. So I mentioned the Federal Trade Commission earlier. They are charged with antitrust enforcement along with the Department of Justice. They have come to the conclusion many times that CON is an impediment to competition that has a negative impact on cost and patients. As you see in the quote up there, an example of regulation that squelches the beneficial effects of competition in healthcare markets without delivering the valuable public benefits that it claims to do so, in cost being one of those. The quality of the provider and the magnitude of the social benefits they provide to the community will not determine the size of the windfall that an incumbent provider with a CON is able to extract based upon their privileged position, especially in terms of those who have regional monopolies because of market concentration in particular areas. As we know, and the experience in Georgia has been, Georgia was one of the dubious distinction of being the only state with 2 regions in the federal health insurance marketplace that had in the top 10 most expensive regions across the U.S. Number 1 was the Vail ski resort area of Colorado, followed by Southwest Georgia, and then South Georgia around Vidalia. That is attributable to the health status of those folks that live there, and also to the market concentration of the provider community in those various regions. So what are the costs of this rent seeking? Economic theory tells us that a privileged market participant will spend up to and the total amount of the rent they are able to extract above what they could have done in a competitive market to protect their position. I think that you all who were there in 2008 sort of witnessed that in terms of the amount of lobbying that has been involved in this issue. Obviously, it's very contentious. You heard yesterday, and there was some talk about the amount of legal work that goes into contesting CONs or defending your CON application through the process. It's long, drawn out, and expensive. Lobbyists and lawyers don't provide patient care to anyone. Economic rents are an attempt to quantify the profit taking in excess of what they would have been able to do in a competitive market. You can also view it as a third party denying the ability of 2 other market participants to engage in a mutually beneficial exchange. and the cost that they can extract from those parties in order for allowing them to go ahead with their business. I mentioned the 2 of the top 10 healthcare regions being in the more expensive range earlier. And again, CON can amount to what is a expensive delaying tactic rather than any sort of guarantor of cost control, quality, or access to service. So this is the problem that you have to contend with. This is a map of counties ranked by their health outcome produced by the Robert Wood Johnson Foundation, but it's a great illustration of the 2 Georgias. Your challenge is that you have to make a law of general applicability that applies to both the metropolitan Atlanta market and the regional market towns where there actually are access and patients with health insurance, and the rural areas where you're charged with examining the issues that how this is going to impact them. The problem is you can't treat one or the other in isolation. Chairman England, we had discussed with you in terms of a bifurcated system and having a CON in some counties with a population at a certain level, I believe 50,000. I've heard some other numbers thrown out. Again, what is the magic number in terms of what would be the right population? Where's the cutoff? If you look at the table of all the counties in Georgia ranked by the percentage of their population on Medicaid, or the percentage of the population that lives below the federal poverty level, and then you look at the counties where you've had a rural hospital closure, this should be no surprise to anyone, but those counties all have higher Medicaid uptake rates than the statewide average, which is 19%, and they have higher percentage of their population living in poverty. There's not a direct correlation in terms of the Medicaid share of every county's relative population. The low is in Forsyth County, 6.6%, and the high is in Decatur County, where 36.6% of the population is covered by Medicaid. Now, the top end of the spectrum, where you have more than 1/3 of the population covered by Medicaid, has actually not had a hospital closure in any of those counties, so it would not suggest that Medicaid uptick is a direct correlation between hospital closures, but you can certainly see where your problem spots are going to be in the future as you examine this. And so the issue is, can you make a law of general applicability that addresses what you're trying to accomplish in terms of rural access, quality, and affordable health care without distorting the market of the more competitive metropolitan areas where you have lots of providers, lots of insurance company choices, lots of hospitals to choose from, all within an accessible area and a short driving distance. And again, I think you have to ask yourself, there's a moral question there, is it appropriate to deny care options to those who would have them in order to prop up providers that exist in a system or in areas where there's less opportunity or ability to have a going concern as a healthcare enterprise because of the rate of uninsurance, the health status of your population, the geographic spread that the population actually lives and works in versus a more dense area, and is there a way to square the circle? So the issue that is brought up continually is that if you mess with certificate of need, then your hospital is going to close in your community. Hospitals have closed since 2008 when we did not address hospital CON in a real fashion. And you have to ask again, if there's a critical access hospital that is barely able to make payroll, are they really going to have a multi-specialty ASC go in across the street the minute that you repeal certificate of need? The question is, why do they rob banks? Because that's where the money is. I believe you're going to see, if you do elect to liberalize the CON regime or repeal it, that the competition is really going to intensify in the areas where there are people that have health insurance or the ability to pay, and that you're still going to have access problems in the rural area because of the lack of coverage and the lack of people's ability to pay for their care. Your Medicare and Medicaid census is being very high in those areas. That's still going to be an issue. And the arguments for CON, in my opinion, are really about protecting incumbent firms from competition. It's not about controlling cost. It can have an effect on quality, but it is a mixed bag at best, and it is restrictive to access. But the issue is that you have CON. There are providers out in the community that have them, and if you take those away, what are the downstream effects going to be? And is that fallout worth it for the gains that you would and we would capture as a state without certificate of need? So you have a couple of options for CON reform. that I wanted to leave you with in terms of recommendations. Of course, you can do nothing and let the law stand that it is. I would suggest to you that if you like what you're getting now, then that is a certainly viable course of action for you all to take, and it will be controversial for you to try to do anything. But you will continue to have this sort of slow drip of a rural hospital closure every year or two as a result, and you're not going to be addressing any of the fundamental issues that are driving the lack of rural access to health care. You could go whole hog and repeal the entire CON statute, Chapter 31.6, in its entirety. It'd be a shorter bill, obviously. And, you know, for those of us that sat in on the negotiations on SB 433, or you could tweak the CON program in terms of going into that matrix, checking boxes, unchecking boxes, raising or lowering the capital expenditure threshold. But, you know, get ready to spend the next 2 years going over the minutia of every particular service and the impact in a particular region of doing that, and you're going to have that in the weeds discussion for many weeks and months to come. Or you could reform, you could do nothing, tweak it, reform it, and then a fourth option that I would suggest to you has merit in terms of giving you better information to make policy decisions around this is to increase the transparency in the system. As you have seen yesterday and you will see later today, CON is very, very complicated, can be very confusing. Hospital finances are even more complicated and confusing. Georgia does not have robust, transparent community benefit standards or reporting requirements. As you heard yesterday, we have our 3% charity care commitment, but that doesn't include the hospital tax that is paid, or it's used as an offset. And then supplemental payments are also not weighed against that 3% indigent charity care commitment that you have in your CON statute. As Rachel mentioned, you know, CON is a prospective approach to getting a permit to operate your business. Licensure, survey, and certification are really the backstops that provide a de minimis amount of guaranteed quality, and those are enforced through, you know, DCH, CMS survey and certification, JCO accreditation. So there are other bodies that are typically more active in terms of enforcing quality and maintaining the integrity of your care and the safety and availability of the facilities that you're at. Lastly, so thank you for giving me the chance to put a quote from Mario Puzo in a presentation. Some of you may have heard me say this before, but this is from The Godfather 3, not the best one in the trilogy, but certainly I really enjoy this quote. And it's politics, finance is a gun, politics is knowing when to pull the trigger. That is your charge, and you know why you all get paid the big bucks as our part-time legislators. And so, you know, what, if anything, you decide to do about CON, obviously is going to have ramifications for your communities, no matter what part of the state that you're from. And do you have to tolerate the cons of CON because it is a historical relic? It's very difficult to change things as they become stratified and built into our system. Point blank, will more hospitals close if you repeal CON? Yes, I think they're probably going to close anyway. CON is not going to be a guarantee of access for those of us who live in communities in Georgia where there just aren't enough bodies to keep the doors open. We've heard that many times, that you need a certain amount of population to sustain a general acute care hospital, and those people are just not in rural Georgia. So I believe, yes, you probably will have more hospital closures, but with or without CON. You know, and the issue is that the hospital, I think this is more of a chicken and the egg type question, but the hospital is really the canary in the coal mine of the rural economy. So, you know, this session has been about healthcare. Your work in the Rural Development Council has touched on, again, how do we maintain a de minimis level of investment, access to care, to make life in rural Georgia viable, and not so have them not be left behind by those of us who live in metropolitan areas. And, you know, really, I think Tolstoy wrote that every happy family was happy in the same way, and every unhappy family was unhappy in their own unique way. So if you look at the rural hospital closures, there's always a local element to what drove that particular institution to close. But really, the Medicare readmission penalty, in my mind, was sort of the tide going out. And in terms of if you have a Medicare-dependent hospital and you're on the hook for a readmission, no matter, again, if it was the fault of the care delivered in your hospital or something else that happened, Medicare can come back and claw back 3% of your, up to 3% of your total Medicare payments for a year. And I really think that that was the sort of harbinger of a lot of the wave of closures we've seen since the Affordable Care Act was passed. So how can policymakers get better data to make decisions? I think you should increase the transparency in the system. There are rigorous community benefit standards that you could enforce. Georgia really doesn't have an enforceable standard. There are requirements for hospital authorities, or hospitals that are run under an authority board, to file community benefit reports with the probate court in the county where they are instituted. A lot of those are not filed. We had a hard time getting a hold of them when we looked at this in 2010. So I think from a, whatever you do in terms of CON, I would recommend that you take steps to increase the transparency that you have as policymakers in terms of the financial health of Georgia's hospitals and healthcare system. To better equip yourselves as you evaluate the pros and cons of CON. Thank you.
Questions?
Jesse, can you go back to the previous slide? This one. Flesh out a little bit that option 2 up there about enforcing standards, what that would look like, and compensate incumbent providers.
So I referred a little bit to the enforcement of standards through licensure and survey and certification. As I thought Rachel's description yesterday of CON as sort of the vestibule of DCH in terms of regulation. And again, they don't really look at the quality of the healthcare services that they're providing after the CON is issued. There are other organs at DCH typically that do that. And so, the reason that that bullet is up there, Chairman, is that if you remove CON, you're not removing the enforcement mechanism to ensure hospital quality. That still exists through their state licensure, through CMS survey and certification, and through their JCO accreditation, which are all completely sufficient in terms of maintaining quality hospitals. Is really the JCO accreditation, is the gold standard, and that is what you as a hospital have to have essentially to continue to operate. In terms of compensating incumbent providers, that's an interesting question. That could be a very long discussion. In terms of the resources that are currently in the hospital industry as a whole, you're concerned about the rural hospitals and the particular venue of the Rural Development Council. I would suggest that the state supplemental payment programs in Medicaid could be recalibrated to have a greater financial impact on rural hospitals. Your disproportionate share hospital program, Georgia has a fairly low DSH threshold in terms of states' hospitals' ability to participate in the DSH program. You could certainly look at having that threshold raised to where the hospitals that are really truly your safety net providers are getting more of a financial bump. And a little goes a long way in a critical access hospital. We are talking about tens or hundreds of millions of dollars in terms of the whole pocket of supplemental payments. As well as, the Indigent Care Trust Fund is the sort of ready-made vehicle for that, and the upper payment limit program, or the hospital provider payment agreement. So those are all 3 policy levers that you have today that you could recalibrate to target the safety net providers that you are trying to maintain a minimum level of access for.
Thank you.
Thank you,
Don?
Chairman. Thank you, Jesse. Appreciate the presentation. You kind of moderated your statements toward the end, I think, when you said that with or without CON, those rural hospitals that were closed probably would have closed anyway. But there's a couple of things you'd said I made some notes on, but I'll just ask you about the one. One of your slides up there said, arguments for CON are really about protecting incumbents in wealthy areas, using the threat to rural providers to prevent, reform, or repeal. I'm not sure. I guess the threat of CON, I guess, is what it's referring to. But how would the threat of it prevent, repeal, or reform? I mean, repeal doesn't even make any sense. But how would that prevent reform for the rural providers? The threat. I don't understand what you're trying to get at there.
So I don't know if I was totally clear in that point, Chairman. The issue is that you, as policymakers, and when I was sitting up on the committee roster and meetings, is that the argument is made that if you do anything to affect CON, you're going to drive a wave of hospital closures. Again, I don't really think that some of the metropolitan hospitals that have large financial reserves or in rude financial health are going to close if you affect CON. They're just going to have a more competitive marketplace to deal with. Now, the issue in the rural market is a completely different world. As I stated before, I don't really think you're going to have a flood of capital investment into a struggling county in terms of let's make a big outlay on a multi-specialty surgery center or a imaging center. So the issue is that for those of you who represent rural districts, the fear is that if you do anything with CON, then you're going to have a hospital closure, which of course is traumatic for a community and not anything that an elected official would want to have happen on their watch. The issue is that you have two markets, the urban market and the rural market. And I think that the rural market and the rural hospitals are in such a precarious financial position that there's a legitimate argument. And so that's why, particularly in policy option 2, I would suggest that you have to compensate those financially who are going to be impacted if you decide to repeal or change CON for hospitals. But the argument has been that you can't do anything because we're going to close if you do.
Okay.
To address your question, sir.
Yeah, I appreciate it. I'm not sure the answer, but maybe we get together later on.
Darlene?
Thank you. Could you go back to the map, your slide of the map of the state? Okay. I noticed looking at Southwest Georgia, there's one county that has the white coloring. It's Lee County, and they don't have a hospital. Could you elaborate on that? They're about to get one. Let's talk about that.
So I'm not I don't have the scars in that particular, battle for, having a CON hospital service in Southwest Georgia. Obviously, that's one of the more concentrated areas in terms of the hospital industry in the state. I think you would see that Lee County has probably higher educational and average income, which would probably contribute mostly to their having a different sort of being an island there in a sea of poor health outcomes. I would attribute probably that to the socioeconomic status in the community.
Would you like to address that, Mr. Chairman?
I think that's outcomes, and a lot of times, to Jesse's point, he's exactly right. When you get into the suburb, and that's the suburb of Albany, you're going to have a more educated workforce, someone that's more likely to have better insurance, to be more educated on the importance of having good outcomes. I don't think it's necessarily relative to provider. Is that fair? Thank you, and Jesse, thank you so much. Me and you have spent hours in the past talking and getting in the weeds somewhat. I want to make a couple of semi-broad comments and get your thoughts on these comments without getting into the weeds. It has been argued or debated that for some of these hospitals, there's only 3 or 4 revenue streams: imaging, ambulatory surgery, those kind of things. And if you open up competition to that, what they argue is you then take away that revenue stream, which makes it even harder for them to maintain a profitability and the threat of keeping their doors open. Let the council know your thoughts on that particular argument.
So
And then
that's
I have some more follow-ups.
That's the cross-subsidization cherry-picking argument. And so if you, GHA's presentation to the council last year has a great slide that I've seen. Can you all hear me? In terms of the payer mix of a particular hospital or the hospital industry, so you sort of have Medicare costs at around, break-even point, so to speak, Medicaid shortfalls. The presentation that you all saw last year had Georgia's Medicaid shortfall about 10% below cost after you include the supplemental payments, which is DISH and UPL. And then you have the uninsured, where there's little to no reimbursement, and then the commercial population, where they're essentially overcharged to cover the loss for the Medicaid losses, uninsured, bad debt, that kind of thing. I think you have to address that, absolutely. So one way you could do that is increase the access to health coverage for folks so that you move them out of the uninsured or the Medicaid bucket. Medicaid enrollment's really driven by larger economic trends in terms of unemployment rate goes down, Medicare enrollment goes down. Unemployment rate goes up, Medicare enrollment goes up. As you've seen in the table I was referring to, the higher Medicaid uptick counties are also below or above the state average in the poverty rate. In addressing the cross-subsidization issue, I think you have to deal with that financially in terms of increasing the reimbursements that you can control. You can't control what Medicare pays for anything or who's on it. You can control who is on Medicaid and what Medicaid reimburses hospitals. You can also, again, take the surplus from the hospitals that are in areas that do have coverage and access and move it out to the true safety net providers in your communities that are struggling to deal with the ability to cross-subsidize. So CON essentially is a barrier to entry on the supply side of the market as a regulation, and the whole ambit, I guess, of my comments is that you don't need to, there's a better way to skin the cat, and it's through financial means rather than regulation of supply.
Mr. Chairman, if I may continue. Sure. The debate has also been that as it relates to the certificate of need, and again, this is a broad statement, that the real battle seems to be in what me and you might refer to as mid-level markets. The metropolitan area has enough competition, it's not as debated as much, and getting the votes within the House or the Senate may be problematic in that area given the pressures that in our constituencies. But if you look at the Romes, Valdostas, Albany's, Gainesville's, that is where the battle is, because the imaging center doesn't want to go to Ocilla. There's not enough good paying patients. And so it's really those mid-tier where there's enough competition there. Is that a fair argument? Is that where the battle is being waged? And do you have a remedy for that?
That's an excellent point. We hear about the two Georgias, and I had that in my presentation. Kind of in some of my discussions with you all, there's really three markets that we're talking about here. There is the truly rural area, or the place where you only have one provider option or none. Then you have sort of the metropole, Atlanta, with lots of choice and lots of people with insurance. And then you do have the mid-market, so your regional market towns, regional economic centers, fall line cities, where there usually is more than one option. And so there you have more of what's a duopoly rather than a monopoly. And that's probably better than having a monopoly in those particular communities. I don't have a remedy for that, unfortunately, for you, Chairman. I think that's just something that you all are going to have to contend with, because the merits of certificate of need are different depending on what part of the state you live in. It's going to be different for those of you who reside and live in Atlanta versus those of you who reside and live in the mid-market cities that you're describing, and then those of you who truly live in rural Georgia.
And finally, one of the things that we don't really talk about is as it relates to the closure of potential hospitals in truly rural areas and not those mid-level markets is the issue, and I'm asking you if you have an idea on that, of the hospital that's servicing an area regionally that goes over into another area and sets up a center to provide some medical, or takes the lone physician within that truly rural area and says, become part of our network. So the referral from that physician, when their patient does need a hospital, is referred to the hospital 30 miles away instead of the hospital 20 miles away. That's certainly for enterprise for the doctor to be able to, the physician to be able to make their decision on who they want to refer their patients to. But I'm wondering if there's not an unintended consequences of being able to then help shore up or hurt the more true rural hospital with that. Have you heard of what I'm talking about? Is there a fix for that?
Absolutely.
It's the will and the spoke.
Right. Absolutely, that's a problem. And again, there is competition for resources in this market. CON is not completely stratified people's ability to hire physicians or offer new lines of service. It is all about the referral back to the mothership, so to speak. I think that's the terminology we use for it. The freestanding emergency departments has been a head scratcher for me, frankly, because we've heard for so many years that all you do is lose money on the ER. And so, I mean, all right, well, let me set up a big money pit out in the, the rural area to get, access to emergency care. It's really about the referral pattern to move back to the mothership of the hospital system.
And finally, one other point, I'm sorry, I know I said just one more, but we had talked on this council in the past about, for lack of a better way of putting it, the micro hospital. And your iron triangle is right on because we have an access problem. This is not a 2-minute answer, but given my respect for you and what you know of this subject matter, is that a viable option? And is that really getting into the weeds on, well, how do you define what a micro hospital is in order to provide that kind of access? Is that a potential option, you think? And if so, could you help us design that?
I think that there's potential for it. I don't know that the economics makes sense for the hoops that they would have to jump through today with how that's been contemplated. And I think you've got to allow people to be creative. So in terms of having a less restrictive system for someone to set up or apply for a micro hospital, I would certainly recommend that to you, because I don't know that, even with all the people in this room, that we would be able to come up with what that model looked like to have a going concern as that hospital. My thoughts on how do you have a de minimis level of, ER coverage, maybe, a couple of beds to get admitted to or be stabilized in to be transferred to a more appropriate care setting. I think you're just going to have to say this is what it takes to keep an emergency department or those critical services that a community has to have to attract other economic development, and write a check.
Thank you, Jesse. Thank you, Mr. Chairman.
Matt?
Thank you, Mr. Chairman. Jesse, I'm kind of switching a little bit, but you talked a little bit about uncompensated care and indigent charity care and the inconsistencies there, and also with the community benefit with non-profit hospitals. Do you have any kind of recommendation or solution maybe to address that and to maybe try to correct
Sure,
any
I think
inconsistencies?
that's a great point that definitely comes into play here when you're talking about if indeed you are going to do anything about CON, you have to get a handle on the transparency of the finances of the hospital industry. So I would recommend that the state adopt the federal 990H reporting standards for cost reports. That is another thing that's changed since the last time the legislature looked at this, both in the CON discussion in 2008 and then the study committee on hospital taxes, hospital tax exemptions that was convened in 2010, is that the IRS has now required hospitals to move to a 990H reporting standard. Right now, there's a couple of duplicative reports that they have to file with the state every year. To me, it would make more sense for them just to adopt the federal reporting standards in terms of what they have to provide to DCH. And that way you sort of have an apples to apples comparison. You also mentioned community benefit. There are some other states that have more stringent community benefit standards, and that is typically, and again, there's no one size fits all for a particular community, and I don't know that it would be appropriate to make a general state rule about what could be in a community benefit report or something that a charity hospital could take credit for. But I think you do need to have them convene a group of stakeholders in their community and reach a mutual agreement on what the community needs in terms of the benefit, because you do have some examples, I think, of mismatch in terms of community benefits that are provided that are not really addressing the real needs in the community. And there's not a ton of accountability in terms of the reporting, so I would suggest that those be more rigorously audited.
When you said that about the 990H, I'm just going to ask a question. I don't know, and I ain't expecting you to know the answer, but I'm going to ask someone to look it up. I think on the rural hospital tax credit program, we do require that those hospitals wishing to participate do file the 990 form, if I'm not mistaken. But I'm going to ask some of our folks at the table to make sure of that. Got time for one last short question?
I got one too.
Rick?
Thank you, Jesse. I think most people need to listen to your presentation again. a time or two to get all the details in it. But you had that big graph, with all the check marks and the states and the procedures, I guess. In the states that have lower CON thresholds, I mean, to be less check marks across the barrier there, are their healthcare costs lower in those states?
I don't know the answer to that off the top of my head, Chairman.
Well, I think that's an important thing that needs to be considered, especially we compare, urban to rural, and how those things they lay out. Do they really make an effect on healthcare costs?
Well, it can't get any higher in South Georgia.
Yeah, I think you're number one, weren't you?
And you may hear about that more from a later presenter today.
Okay, thank you, Jesse.
Okay. Jesse, thank you. As always, incredibly impressive. Thank you
Thanks,
so
Chairman.
much for the time you put into the presentation, and go rest your voice for a
I
little bit.
apologize for the frog in my throat, y'all.
No, you're fine. Next, our next presenter, most every one of us knows David Tatum with Children's Healthcare of Atlanta. He is among the first 4 or 5 folks in the Capitol every morning during session. And I always question how my day is going to be, whether or not he's sitting outside my office door when I roll in at about 6:15, if it's about to be a bad day or a good day. So David wants to talk to us just a little bit about children's health care, of course, but also a little bit about CON's impact on them as a medical delivery system as well. David, thank you.
Thank you, Chairman and members of the committee. I filed my first CON in 1984 when I worked for Charter Medical Corporation, a now defunct hospital company that was based in Macon, and I'm convinced I reported to Satan because I saw the guy's social security number once it began with 666. But I've come a ways since then. I'm now with, it's still not, Children's Healthcare of Atlanta, which you may know was formed by the merger of Eggleston Children's Hospital and Scottish Rite Medical Center back in 1998. And we are the only freestanding dedicated pediatric health system in the state. We've got 638 beds. We also operate the Hugh Spalding Children's Hospital for the Grady Health System. We've got a number of outpatient centers and neighborhood locations. And back in 2008, we took over the operations of the Marcus Autism Center and are very proud to have that as a part of our system. Last year, we saw over 390,000 individual children generating over 1 million patient visits. That's more than the population of Statesboro, Valdosta, Savannah, and probably Albany, all coming to us for care. To me, that is a stunning statistic, and we keep growing. And at the same time, 59%, nearly 2/3 of the kids that we treat are covered by the Medicaid program. By payer mix, we're the largest Medicaid provider in the state. And even with the rate we get and the add-ons from the provider fee, we still lose about 13 cents on the dollar of cost, not charges, cost, on the Medicaid treatment we provide. You don't make that up on volume. The more you see, the more you lose. And I'm not expecting that to change, because for the past 10 years, a little over half the kids born in Georgia have been covered by the Medicaid program, and that doesn't show any signs of being different. Well, a couple of years ago, we were approached by a few hospital systems about putting our services in their hospitals. And we've had a lot of discussions with them and came up with a proposal that we originally ran by the department to allow us to co-locate children's beds in their facility. But because the current CON statute does not contemplate, nor do the current CON rules contemplate, this type of entity, we wanted that entity defined. It would allow us to put, say, 10 to 14 beds at an adult system in the metro area or in a rural area. We could work it either way. That would put children's services in that local community. at a pretty low capital cost. DCH recommended we go the legislative route. Madam Chair Cooper was kind enough to carry Senate Bill 81 for us in the last legislative session. It actually passed her committee, I believe, by a vote of 20-1, but we elected and requested to withdraw it because of a reaction from other members of the hospital community that saw that bill as a vehicle for some potential other changes to CON that were not particularly palatable to them. Hence, our desire to run this through the process before the next legislative session, vet it, and my presentation to you today. But Senate Bill 81, in the form that it came out of committee, is in front of you, and I want to make clear that it is not a CON exemption. It is simply another definition of a CON covered entity. The full review process remains in place, the same timeline, the same appeal process, everything. All it does is add another category. And it's not something we can do arbitrarily. We have to be invited to the table by an adult hospital. That hospital and we have to co-apply for the beds that are to be located in that hospital. And if our marriage with that hospital is ever terminated, then those beds don't come to us, they go back to that hospital. It accomplishes a couple of things. It expands pediatric services around the state, and that didn't change. There's a CMS rule that within 35 miles of one of our facilities, those beds can be on our license and our provider number. Outside of 35 miles, we would have to form another subsidiary entity, and it's not restricted as to where in the state it could be. The Medicaid rates and other things would have to be worked out, but I want to make sure people understand that this could have a significant benefit for rural areas, and it's a fairly low capital cost to bring our services in. Before I take any questions, I was asked, what do y'all think about CON? Is it good, bad? And I'll tell you, when I was with Charter Medical from 1984 to 1996, until a guy asked me to lie to a congressional committee and we parted ways, I actually lobbied against CON. So I know most of the arguments that Jesse put out one way or the other. But I do think that CON has some value in protecting some of the more vulnerable hospitals in the state. I think there are some opportunities for modification. I believe the capital expenditure threshold position that's been advanced has some merit. I know that a lot of hospitals, including we, try to design our projects so we go below the capital expenditure threshold and do not have to apply for a CON and therefore avoid all the time and cost associated with it. But it may not be the best option, but we do it consciously. I know everybody does. CON does probably have some value for making sure that new entrants into the marketplace have some type of indigent or charity care requirement associated with what they plan to build. I am reminded that the CON process goes beyond indigent charity. There's actually a provision in the general review considerations that the department's supposed to look at whether the applicant's anticipated Medicare, Medicaid, and free care reflects the profile of the people that live in that area. And if it doesn't, they can turn the CON down. I guess where I'm coming down is, after 34 years of debating this, I'd like to see the discussion shift and get through whatever needs to be done to CON done. Because for us as providers, doctors, hospitals, nursing homes, others, I think the real task and the real challenge is going to be dealing with the finances of healthcare and therefore reimbursement. I think changes are coming down out of the federal level that will require the state to step up and respond. And waivers were talked about yesterday. Some of the news I read from Atlanta when I got up this morning, they're becoming more and more of a topic in the campaign, particularly the gubernatorial campaign. And I think this state, if they're going to do something, needs to make sure whatever is done adequately and rationally provides reimbursement for the provider community. And the House took great leadership last year, and the General Assembly passed additional rate increases for certain physician codes. It's made a big difference. But in my mind, it doesn't matter if you get a waiver to cover someone. If you can't get a provider to accept payment from Medicaid, that coverage is not going to occur. I'll be glad to answer any questions.
Thank you, Mr. Chairman. David, thank you for your presentation, and thank you for allowing me to carry that bill. And I would like to say to the committee and put it out, regardless of what happens on CON, I would like to be able to carry that bill again. And you may not know, but I taught pediatric nursing to nursing students. Children are very different, and the care they receive, especially in emergency and serious medical conditions, is very different from that of an adult. And I would like to see that be available in more places in our state, besides just in the metro area where parents with children from outside that area have to travel many, many miles, or over in the Augusta area at their children's hospital. I have opened up the CON law since 2008 on the request of the hospitals. I told them at the time that I would not allow anything else to be put on that bill. If anybody tried to do it, I would come to them and see if they wanted that change made, and if they didn't, I would kill the bill before I would allow it to go forward. I made the same commitment to the hospital people on the one for children, and I would make that again, and I think y'all know I'm a person of my word, and I have done it for the hospitals. So I hope, regardless of what we do on the rest of it, that we might be able to move forward to make the kind of care that children's hospitals and the Children's Hospital with the Medical College in Augusta, that they provide to children across our state. Thank you.
Thank you. As the loyal secretary and former vice chair of health with Chairwoman Cooper, she is 100% accurate. We have had discussions, I remember this bill, about not letting it be a vehicle. And I'm not going to ask you what happened, because usually when we give the word that we're not going to let someone amend, you know, I've seen this movie. She's left and she says no amendments. I've run my own committee that way, so I'm a little confused on exactly what happened. I know you can't wait to talk about that offline with me.
I might talk with you online.
All right, go ahead.
Well, the reaction from some of the other members of the hospital community was not positive. And we elected to, instead of causing additional furor near the end of the last session, we elected to withdraw and go this route. And we're fine with having it fully vetted. We think it's a great idea, and we hope it receives support next time around.
And I was hoping that would be your answer, but there's a part of me that goes, but if you've got the word of the chairwoman that nothing's going to be amended to it, and you're getting what you obviously believe is good for children in this state, because if it does get amended, something's going to happen in rules, I can promise you that. Why wouldn't you just say yes?
David, let me answer that one for you.
Thank you.
Because he may not want to say that his hospital administrator received numerous calls, I won't call them threats, numerous calls of persuasion from other hospitals across our state in not letting the bill go forward.
Jay, I have a question.
Thank you. And then finally, if we see this, because I like this bill, if we see this, and the same question I asked yesterday to the nurse practitioners, if as a last resort, because everybody uses, we're doing this for rural Georgia, and then sometimes we don't actually see it in rural Georgia. At a bare minimum, would you be willing to roll this out in some kind of pilot program in rural Georgia specifically?
If someone invites us in rural Georgia, we're happy to.
I just don't want to be told, David, you know me, I just don't want to be told this is for rural Georgia.
No,
and then we don't end up getting any of it.
I'm not going to make that representation. This bill is specifically written so that we can get around that 35-mile CMS and go out into rural Georgia. But again, we have to be invited to the altar, and everybody's got to agree it makes sense, and the whole due diligence process.
All right, thank you.
Thank you.
Excuse me,
Penny?
Mr. Chairman.
Wait a minute, Penny?
Uh, You mentioned something about a hospital that might be, a rural hospital might close, not a rural hospital, a large hospital that would potentially close if we did away with CON. Did I hear that right?
No, ma'am, I don't think so. My position was that CON serves, in my opinion, a role to protect certain vulnerable hospitals.
But one thing too, we find in rural Georgia that the CON laws keep down competition so much, but yet the hospitals are buying up doctors' practices, they're expanding and buying hospitals everywhere. And I know in my area, I had 2 hospitals bought up with no due diligence done. It was just almost like you're competing against each other to get bigger and bigger and bigger. And I have a problem with that. And
I
I have a
understand.
problem with all the doctors being bought up and have to kowtow to the hospitals.
Well, there's some changes at the federal level on Medicare and site neutrality and the like that may address some of the doctor concerns. No more can you just buy a doctor practice and offer services off-site within a certain distance of a hospital and still get the Medicare rate. But CON to me is, if you're going to keep it, you need to strike a balance within it. That was my only point.
Well, and I think it's going to be interesting to see what happens in Lee County. You know how expensive health care is in southwest Georgia. When they open that hospital up, having competition, or we're going to see health care come down.
Don't know.
Don?
Thank you, Chairman. David, thank you. I remember I remember your bill, and I may have voted, I think, anyway, I know I was against the main bill. I don't think I was against your bill, but my question is, you were talking about this, putting the 10, 14 beds in a facility, rural or metro, which seemed, it seemed like a really good idea. And then you had said, and I think you explained this, I might just miss some of it, you probably explained it in committee too, but you said, in this presentation, you said you decided to go the legislative route last year, and then you're going to decide to go, but my question is now, and I really, just because I want to know, now, I think you alluded to the fact it would be possible through what we have now, but it would be problematic. Is that correct?
We
it would be
believe-
possible with the CON we have in effect now, but it would be problematic to do what you're talking about. Is that correct or not?
We believe that what we would like to accomplish can be done through the rulemaking process at the Department of Community Health. And we approached them, and they were very open and very cooperative and great to deal with, but at the end of the discussion, advised us to go through the legislative process, hence we did that.
Okay. Well, then my question is, is that something, and here again, just trying to understand, now, what makes it problematic, is that something that they could fix, or would it have to be fixed through legislation?
Again, I think it could be done largely, if not completely, through the rulemaking process, but for long-term not dependability, long-term viability, may be preferable to do it in statute. We could go either way.
Okay, I got you. Thank you. Appreciate it.
Terry?
Sharon?
I just want to say that it wasn't just Children's in Atlanta. If I remember correctly, the Children's Hospital that works with the Medical College of Georgia was also in favor of this. They're sort of set over in an area that touches more of our rural southern areas, and they were willing to participate also and thought
That's
it was a
correct.
good idea.
We-
So it's
we-
not just Children's in Atlanta, it's our Medical College of Georgia and their children's
I
hospital.
think you're correct, Madam Chairwoman. We had discussions with Augusta University, and I think operated by state medical schools, even referenced in the language of the bill.
And for Chairman Parsons, I think there's been the accusation, right, wrong, or indifferent, that some providers shop legislatively or through the process, and I think there's been a movement away from doing that, because if you're going to do an end around the legislative process, you get some questioning about that, and I think the mood has been recently to do it through the legislative process as opposed to looking like you're going around it. Would you think that that's a concern some people have had recently? We can cite examples, so that the answer would be yes.
Yes. We didn't think about it that way. We
Right, I know,
originally approached
I
it
know.
administratively.
Others.
Okay, I think that we've got to move on. We appreciate you coming and talking to us today, and thank you very much. Our next presenter is Kimberly Anderson. She is a graduate of the University of Alabama School of Law and has practiced as legislative counsel to the United States Senate Committee on the Judiciary and has represented clients in all phases of the regulatory process and is a member of the Robbins Law Firm. And she's going to be joined by Roy Robinson, who we all know, and we want to welcome both of y'all up here and tell us what we need to know.
Sure. As the chairman mentioned, my name is Kimberly Anderson, and I work at the law firm of Robbins, Ross, Alloway, Belafonte, and Littlefield. Most of you guys know Josh. I'm here on his behalf. He is observing Yom Kippur right now. And we represent Hospital Corporation of America, HCA, and it has been asked a few questions regarding HCA's experience in states both with and without a certificate of need. Just by way of an overview of HCA, it is the largest hospital system in the United States. It operates in over 23 states. HCA facilities provide 5% of all inpatient care delivered in the U.S., and it provides more Medicaid, Medicare, and uncompensated care services than any other provider in the United States. So that's nationwide, and here in Georgia, we have a strong presence as well. We have 10 hospitals throughout the state that sort of run the gamut. We have both rural and urban hospitals. We have 2 rural, one in Fairview Park, and the other is Satilla. And then we also have kind of a wide range of hospitals. We have a teaching hospital in Memorial. We also have a children's hospital there, and then we have hospitals with level 1 through level 3 trauma designations. In fact, HCA operates, I believe, half of the level 3 trauma centers here in Georgia. The level 1, just for your information, is Memorial, and level 2 trauma center is Doctors in Augusta. As you can see, HCA is a tax-paying hospital system. It pays over, here in Georgia, it pays over $43 million in state and local taxes. And it's had an investment of $817 million in Georgia. And that does include the taxes as well. And as you can see, it is also, not only is it the largest provider of uncompensated care nationwide, it is a large provider of uncompensated care here in Georgia, with providing over $108 million. So the question we've been asked today is how does CON laws affect, or how has HCA seen the effect of certificate of need laws as to patient access, outcomes, and affordability in the states where HCA operates? As you can see, we have 5 comparator states. Just by way of explanation, we used a mix of those states with CON and those without CON. And as Ms. King mentioned yesterday, Indiana recently enacted a certificate of need system, but the data we're using here was when it was a non-CON state. And so so Georgia obviously is at the top, and then Texas and Indiana were those states that we considered to not have a certificate of need regime, followed by, and then the others, Florida, Tennessee, and South Carolina. It tends to go least restrictive to most restrictive in our minds. South Carolina is very similar to Georgia. And so why do we look at these states? So that's just kind of the background of the certificate of need situation, but we looked at these states, as you can see, because they do have similar Medicaid populations, uninsured populations, as well as a urban to rural population similar to Georgia. I believe Jesse and Ms. King gave a great overview of certificate of need here in Georgia, so I'm not going to repeat anything that they said, but I did want to briefly touch on Florida, Tennessee, and South Carolina, what their certificate of need situation is. Florida, they have no threshold requirements for capital expenditures and equipment. And also, all ambulatory surgery centers are exempt from CON review. Tennessee recently reformed certificate of need back in 2016. They eliminated capital expenditure and equipment thresholds, and they've exempted several facilities from CONs, such as OB services, birthing centers. So it seems to be those that tend to have more of a need for the patients. And then they've also enacted a modified exemption for existing hospitals. As I mentioned, for South Carolina, it's very similar to Georgia, regulating similar services, similar facilities. It has somewhat of a lower equipment threshold at $600,000. I believe ours is around $1 million, roughly. And then the capital expenditure is roughly the same. It's about $2 million. So as I mentioned, we were trying to find the data related to patient access, outcomes, and affordability. And just as a note, when we were looking at patient access generally, a lot of the data out there deals with preventative care, primary care. How are patients getting it at the ground level before they present at the emergency room with a traumatic situation to where they can't do anything about it? And as most of you know, that type of preventative care is not regulated by certificate of need. So we don't have the data up here, but as far as we were concerned, the certificate of need and any type of reform would not really impact patient care at the preventative care level. And as you can see for, it went past. Yes, so this is the outcomes. And as you can see, you can draw conclusions for yourself, but we're not statisticians. I don't purport to be. There's no clear answer, or we do not necessarily see a direct correlation between health outcomes and certificate of need reform. What HCA has seen is that CON does impact the way hospital systems operate, the way the business model is. And quite frankly, HCA has been able to adapt to each of those states, and not only adapt to survive, but also have operated successfully, and they continue to expand. HCA has expanded here in Georgia. It expands in other states that don't have CON. So as I said, these are some outcome data we pulled. Generally speaking, Florida tends to have the best outcomes. I've highlighted the winners, so to speak, the ones with the best. It's a little confusing, but the life expectancy, the higher rank you have, the better, because those people are living longer, whereas the cancer incident rate and the heart disease deaths, the lower tends to be the better outcome. So with life expectancy, as I indicated, Florida, and then there's followed by Texas, and then Tennessee tends to have higher life expectancy. But it's important to note it's hard to draw these direct correlations to certificate of need because there's other factors out there. It's the culture, it's your lifestyle, it's the demographics, it's the location. Florida, maybe people just prefer the beach and are generally happier there. For the cancer incident rate, just to show a summary, the winner is Texas, again, followed by Florida. And actually, our own state, Georgia, had the highest cancer incident rate. Then with heart disease deaths, again, the winner was Florida. And it was actually by far, as you can see, with they were ranked 39th. And then all the other remaining states tend to be somewhat closer lumped together. The last segment that we looked at was affordability. And here you can see somewhat of a correlation between certificate of need reform and affordability. And the way we looked at that is mainly through the employer-based annual premiums, as those are the impacts that patients are going to have. Those are going to be passed down to the citizens and the constituents. Hospital expenses, those vary widely, but that's going to be borne by the hospital itself. The constituents with the insurance rates, how their coverage is, that's what is going to be felt. As you can see, Tennessee actually has the best. Just a couple of things, and then I think it was followed by South Carolina. Important to note with those two is those states tend to have a lower cost of living. And then also with Tennessee, they had a kind of an interesting Medicaid expansion where you can use Medicaid dollars to buy private insurance. So we think that may impact that as well. But the other three, Texas, Indiana, and Florida, those all have enacted some type of CON. And again, recognizing that Indiana recently enacted certificate of need. And so finally, what HCA recommends as far as reform is concerned, and how we believe that impacts the rural areas of Georgia. We have supported in the last legislative session House Bill 299. Quite frankly, we don't believe it has an impact on rural Georgia. It addresses 4 essential areas: elimination of the capital expenditure and equipment thresholds. This is only for certificate of a need approved facilities, those that are governed by 31-6-40. So it would not touch the statutorily exempt ambulatory surgery centers. We believe that eliminating these, I know people have touched on it, would provide the ability to update equipment and expand the services that, quite frankly, the hospitals are seeing for their community, the demand that they see in their community without having to go through rigorous process, or, as Mr. Tatum pointed out earlier, trying to figure out a way to get under the threshold while also updating equipment or trying to provide some flexibility. This would also deregulate hospital behavioral health services. We believe this meets an unmet need here in Georgia. Currently, they have closed 3 state hospitals under given a suit by the Department of Justice, the Federal Department of Justice. Freestanding psych hospitals are somewhat limited in the types of patients that they can accept, the funding that they can accept. They cannot accept government funding. And so we believe the deregulation of behavioral health services would create ability to address that need to help with this shortage right here. And quite frankly, it would also help counties and sheriff's departments. We've had stories from our hospitals where a patient is presented to our hospitals that do not have psych beds. They have to stay until, for a week or so until they can be transferred, until a bed has been located. And that's obviously costing the county money for transfer, for keeping them in an expensive emergency department bed. The third point is to allow for bed expansions more easily for those existing CON hospital facilities. This would allow, it's not a huge jump, it would go from a 10% to a 20% expansion, as long as the hospital has capacity at 60%. Currently, if you have 75%, you're over the 75% threshold for 2 years, you can expand by 10%. So this would allow, if you've met 60% for 2 years, you can expand by 20% your number of beds. And finally, it would exempt from CON freestanding emergency departments, but these are somewhat different. They have to be tied to a hospital's license, and they have to be located within 35 miles. HCA has experienced success with freestanding emergency departments in other states, and we just believe, especially in urban areas, and it's just another way to get out to the community and meet those emergency needs without having to travel back and forth. And with that, I will take questions. I don't believe I have the question.
Penny?
Your first point, when eliminating the threshold of capital expenditures and equipment thresholds, is that for ambulatory surgery centers, you would limit the expense threshold?
No, so HB 299 would not touch the capital expenditure thresholds for ambulatory surgery centers. The threshold for ambulatory surgery centers is set out, I believe, in OCGA 31-6-4718, and it does not.
But
that
why
means-
would you want to limit them from having the finest equipment and make them, and it looks like that should be the same, just do away with that too? I don't understand. I don't understand why you would limit.
Then that's fine. We were only addressing the hospital situation.
Oh, you're just
that
addressing the
that we were.
hospitals.
Yes, ma'am.
But doesn't the ambulatory surgery centers come under this CON? You would just,
Ma'am, again, if you'd like to do that, that's fine with us. We just need it done on both sides.
I didn't, I just, it seems like you would just, I think we need to look at everything.
We don't have a problem with that at all. Thank you.
Thank you.
Sharon?
Mr. Chairman, thank you for the committee. If you don't know about the thresholds for freestanding surgery centers, I can't remember what the threshold is now, and there was a chance for it to go up. But it governs how much you can spend on the whole center and developing it out. And a good example for one of them is ophthalmology. Someone I know owns one. The ophthalmology equipment is extremely expensive, and the threshold was so low that the center has the ugliest flooring I've ever seen, and the only way they could make it a little bit better was to put a pathway in colored tile, because they spent every cent they could possibly spend on the equipment. Because the threshold's so low and what they can spend, they had to buy not brand new equipment, which they wanted to, but refurbished older equipment, because the threshold was so low that they, wouldn't be able to meet the requirements of getting the center open if they bought new, and that happens, and that's what Penny's talking about. When we do that, it limits their ability to buy, and hospitals too, to buy the best for the patient. So I think for both areas, if it's not eliminated, it certainly should be increased, because equipment is much more expensive these days for all sorts of areas.
And we obviously agree with that. And just for your information, for a single specialty ambulatory surgery center, which we were speaking of, the capital threshold cannot exceed $2.5 million.
And
So-
one piece of equipment can cost almost $1 million. It's just
That's
unbelievable
correct.
in a center.
Anybody else? John?
Thank you, Mr. Chairman. One of your slides showing the cost per inpatient day, Georgia was $16.65 per day, and Texas, who doesn't have CON, is $22.92, which is a 37% increase over what Georgia's paying. What's the reason behind that? Why is Texas so much higher?
I'm not sure. I can look into why it is so much higher, but those are hospital expenses. That's not necessarily hospital costs, and there's all kinds of formulas when you deal with those types of figures. But I'm happy to look into that and see if there's an answer for you.
Just curious, it's almost 40% higher than Georgia.
Right. And like I said, I can look into it if you would like me to.
Ed?
Just real quick, back to the capital expenditure. From an HCA perspective, then if you get a bill on the capital expenditure, and it basically, let's just start with eliminates, we won't see any lobbying that says no, reduce our cap or eliminate our cap, but go against ophthalmology or general surgery. Y'all are going to be on board for elimination of all.
If we get a bill that eliminates thresholds, we would be okay with thresholds. We gotta look at the whole bill, to see if.
I don't want to hear you worked it in the Senate and worked it differently in the House. And not that we've ever seen that movie before.
Well, you're right. Not that we've ever seen the movie before, too. You give us one, and then
Right.
everything else is not good. So we're looking at we'll look at the complete legislation. If that is part of it, that will certainly help. But we'll look at the complete legislation
So
and
you
go from
can't
there.
commit at this time that you would favor universal for everyone.
We can't commit at this time
That's
that
fair.
we would support a bill that we have not seen.
Well,
Come on. You would never do that anyway.
Well,
You get the premise of the question.
I do.
I don't want you to fight on one front, support on another, because I've just seen that movie so much, and we get caught up in the weeds when that happens.
well,
If
please
we-
remember, we've got to do what's best for the people of Georgia.
And that's what we're doing. If you're talking about
I
access.
can't understand that.
If you're
those
talking about
numbers up
access,
there.
if you look at that last slide, every one of those helps with access. I mean, time will tell what we get and what we see, what we support. We're telling you what we'll support.
Mr. Chairman?
Yes, ma'am. One more question, then we're
Okay,
gonna break.
just to be perfectly straightforward in how it really worked in the CON, I mean, they represent a certain entity. They've come up with something that they need that would help them, and what they've done by saying only hospitals is eliminate a great big deterrent over this side, because one of the biggest oppositions to everything in the last discussion was hospitals versus the freestanding clinics. And so if they had put that in their bill, then they would have most of the people sitting back here representing hospitals complaining about that part. That's just the truth of it. There was this, hospital versus the freestanding health clinics. And so they're protecting them, so they were protecting themselves, I'm saying this, by just making it specific to what their needs were. And to put it in for the freestanding clinics would bring great opposition. In the past, I hope that's changed.
Would you explain to me on your chart what, like 42nd and then the 40th? I can't get any correlation between the way those things are ranked. What does the parentheses mean?
Higher the number, the better.
It's the rank over throughout the U.S.
State rankings, okay.
So, for example, Tennessee, so I'll take the employer one. Tennessee has ranks 47th out of 50th as far as the lowest.
The higher the number,
Well, I
the
was
better.
looking at Tennessee, it's 40th.
Backwards.
Oh, I was looking at the annual employer-based, but for hospital
Yeah,
inpatient.
I've tried to have,
There's only
have
8 states
a
got
little trouble with those figures.
So
in
for the
ranking.
rank, the 40th, that means the higher the number, the lower the expenses are. And it's looking at, we were just showing you where it ranks over the entire United
higher the-
States.
Higher the number, the better.
Okay.
Thank you very much. All right, we're gonna take a break and be back here at 10 minutes after 10. 10 minutes after 10.
All right, everyone. We gave you about 4 extra minutes, even though we were running ahead. Now we're running behind again. So if everyone would please take your seats. And we have our next presenter in queue. And we're getting ready to roll now. Our next presenter, we've been talking about CON and whether we love it or hate it or indifferent to it. Texas several years ago eliminated CON, so we felt like that it was probably a good idea to hear from someone that has gone through this process and had enough time under their belt to kind of understand what the ramifications were of a total and complete elimination of CON. So we've asked John Hawkins with the Texas Hospital Association. He's Senior Vice President of Advocacy and Public Policy, to come and kind of tell us a little bit about what's happened in Texas, what they've seen, any other adjustments that they may have made after rolling CON off the books. And so, John, thank you for traveling to Statesboro, Georgia, and the podium is yours.
Great. Thank you, Mr. Chairman and members. And again, what I hope to do today is give you a little bit of a landscape of what the hospital and healthcare market looks like in Texas. And really talk most specifically about really an unintended issue that has popped up, which has become a challenge in Texas and particularly for our rural hospitals. And that's the proliferation of independent, non-hospital affiliated freestanding emergency rooms, 24-hour facilities. And I believe I've provided a handout that we used the last legislative session because there was so much confusion in this space, and I'll talk a little bit about that. But let me just start and give you a little bit about the landscape in Texas. So obviously we're a big state, lots of hospitals, about 621 hospitals are licensed in Texas. Now, interestingly enough, when you look at that, the makeup, it's about a third government-owned, a third not-for-profit, and a third investor-owned. So it's more or less maintained that profile as we've gone forward. So we basically, within that space, have 460 urban hospitals and about 161 rural hospitals. So again, when I saw that map earlier, really, we have several different urban areas, but a lot of the same dynamics exist with the metropolitan areas versus the rural space in Texas. So when you look at the margin of hospitals in Texas, I think we're doing pretty well compared to a lot of other areas of the country, and a lot of that is because of the economic growth in the state. So our urban hospitals have about, on average, a 10% margin, which is good. That's being challenged now with a lot of the payment mechanisms reductions that are all coming to a head. And again, this data is about 1.5 years old. Our rural hospitals, that margin drops to about 4.7%. Again, works pretty well in some areas, but the rural hospitals are certainly more challenged. Now, here's the interesting point. Even within those margins, 30% of our urban hospitals have a negative margin. And so again, I think the way that's working is we're able to ameliorate that within systems. And when you look at rural hospitals, 41% have a negative margin. So really, that's where the challenge is going forward and the headwind. And notwithstanding that growth, I think the latest figures say about 1,000 people a day are moving to Texas. A lot going on in the oil and gas industry, the Port of Houston, no income tax. So it is a state that's attractive for new people to move in, but there are still significant challenges. We lead the nation in the number of uninsured, 5 million uninsured, which is a challenge. Again, we've got a lot of service industry jobs. We're a border state. That has some challenges as well. And you may have even seen the data that came out recently about the metropolitan areas. And Houston actually is the city with the highest uninsured rate in the nation at about 18%. So the result of that is hospitals are reporting at cost, this is not charges, more than $7 billion a year in uncompensated care to the state. Now, we're able to offset some of that with our waiver, which is our old UPL program, and we have a $1.5 billion in DISH funds, but there is still a significant shortfall, uninsured bad debt and charity care that all of our hospitals are having to deal with. And again, that creates challenges when you look at the other payment shortfalls. Certainly, I'll talk a little bit more about what's going on in the Medicare program, but there was some discussion earlier about the Medicaid shortfall in Georgia. We're paid in Texas about 58 cents on the dollar in our Medicaid program. Our Medicaid shortfall is $2 billion a year. So that is a cost, that's getting shifted on to the private market and to local taxpayers if you're in a taxing district. So when you look at our rural hospitals, only 66 of the 161 provide OB services. So that's a challenge from an access standpoint. And we've actually had 19 rural inpatient hospitals that have closed since 2013. Now, 3 or 4 of those have come back online. 3 operate only emergency rooms right now, but that is a real challenge for those communities, as you can imagine, and we're fearful that trend will continue. So obviously, we repealed, CON back in the early 80s, and we have a fairly, robust provider network. And I will admit that free market approach has clearly allowed us to meet the needs of a growing state. To really, when you look at the systems, their ability to move into different areas has certainly served the state well, given that growth. But the challenge is we're one of the few remaining states that has a strong corporate practice of medicine prohibition. So healthcare facilities cannot directly employ physicians. As such, we still have a very independent practice of medicine by and large out in the state, notwithstanding what's going on with a lot of the clinical integration efforts. And so what we see is a tendency of really non-healthcare, out-of-state venture capital type firms that have come in and have basically pitched deals to certain niche markets in our healthcare industry to create independent freestanding medical services. And I think that's a challenge. Jesse had a slide about the problem or the challenge in healthcare is it doesn't necessarily work like the rest of the market. So if you build more, you get more care, and sometimes that is not always the best thing from a cost standpoint. And so I think that's really what we've seen with this proliferation of the independent freestanding ERs. Most of those are the result of out-of-state venture capital firms that have come in and created these with a business model that creates challenges going forward. So just to give you a little bit of more detail on kind of how that manifests itself out in the market. And again, we began licensing non-hospital affiliated freestanding ERs in the early 2000s. There were a lot of different reasons for that. I think mostly it was the argument that if we allow these to be created, it will create more access and drive down cost. But I'm not sure that's necessarily been the case. So we have 146 hospital-affiliated freestanding ERs in Texas. And contrast that with more than 220 independent freestanding ERs. And then obviously there are many urgent care facilities as well, and those are licensed similar to a physician office because they're typically not 24 hours. Now, as the folks from HCA pointed out, a lot of our systems have used these freestanding or the hospital-affiliated facilities to actually improve the care in their communities. They're able to offload care off of their mothership ER, create better access to services. For example, in Houston, folks don't necessarily want to drive down, fight traffic and drive down to the medical center. So in appropriate circumstances, these have been really a help from a customer service aspect as well as a quality of care. And again, those facilities, I would argue, have a legitimate reason to charge a facility fee because they have a real transfer agreement. They are ostensibly offloading some of that stranded cost from the mothership as well. So it is something that tends to work well. But I think many of our members are also having to build those defensively in certain areas of the state to fend off some of these other operators that are out there. And so obviously that, I would argue, that is not a good use of capital and or our medical staff out there. So what are the quantifiable impacts of the proliferation of these facilities? And so we've got several data points, and I'll start with our employee retirement system. We saw some real, or have seen in both our employee system and our teacher retirement system, a real increase in utilization of these facilities. And our ERS reports that the average paid visit for a hospital-based ER is about $2,260 versus almost $5,000 for an independent freestanding ER. So again, some tangible inflation within our employee system there. And then, more important for this group, I think, is the challenge that our rural hospitals have experienced. And again, it was interesting when we first debated this issue about whether or not to license these facilities, our rural hospitals weren't necessarily engaged because they knew, because of the fiscal challenges and access challenges in their area, these facilities wouldn't necessarily locate there. But now they are very engaged because what it's done really to our provider community. And so our rural hospitals estimate that more than 1,000 physicians have been drawn away from existing health care facilities, and these are mostly coming from hospital ERs. And, you know, it has a negative impact because it has created a shortage of emergency room physicians, and now we're seeing nursing staff. These facilities have drawn nursing staff away from our rural hospitals as well. When you look at just the way the network works, and this is data from our Association of Health Plans, they report that within the 3 largest health plans, a range of 21% to 56%, depending on the plan, of hospitals have no in-network ER doc at these in-network hospitals. So again, we've seen the niching off of that service line, which has been a challenge. And so for the rural hospitals, what that has meant is many of them use contracts, visiting contracts for emergency physicians, and they estimate that their annual physician cost has increased $200,000 to $400,000 a year. So again, a very real impact out there. And again, you know, this is a cost that then gets shifted on to taxpayers if you're in a hospital taxing district, or the private market premium, and that may have been reflected in some of that data that you saw earlier about why premiums are higher in Texas. So just a little bit more granularity on data that our health plans have. Freestanding ERs can be 10 times more expensive than urgent care centers, with a 75% overlap in services. So again, providing more or less the same services, but at a much higher cost. The health plans say ER spending by one major health plan is 67% higher than the rest of the nation. This is a health plan that operates in a lot of different states. Average ER facility charge in Texas is 36% higher than the rest of the country. And the health plans have seen more than a 12% increase in ER cost per year. So to kind of wrap up, and then I'll take questions, great discussion earlier about really the dynamics of facility siting. And I think we have seen in Texas that these facilities typically do not serve the general public per se. but they are focused in certain areas, more affluent areas of the state, more affluent zip codes. And there's actually MedPAC at the federal level has some good data on that. It's created confusion out in the market about a freestanding ER versus an urgent care center. Folks don't understand facility fees, and a lot of these facilities are out of network, and so that creates confusion about whether they may say they take insurance, but they don't necessarily tell you they are not an in-network provider, and that has created cost as well. And I think, there's been a lot of discussion, too, about potentially at the federal level a step-down classification for rural hospitals. And I think, Jesse actually kind of teed this up well, too. I think we would argue the real reform for rural hospitals is going to come through comprehensive payment reform, particularly on the Medicare side. And really what we've talked about in Texas is we need a different Medicare model for rural hospitals, and then it will be up to the states to sync up their licensure statutes to match that, because really the payment challenges in Texas are mostly on the Medicare side because of the Affordable Care Act cuts. Sequestration, remember the 2% is still in place. That's hitting our rural hospitals hard. And then we have the underpayment in our state Medicaid program. We're 95% managed care now, so that's a challenge for our rural hospitals. And then we just got a new supplemental payment waiver where the federal government is going to reduce the amount of the Medicaid shortfall that they pay. So again, all of those challenges, I think, are the reason with this proliferation of freestanding independent ERs where you've seen those rural hospital closures. And so finally, Texas does, like most states, have state licensure requirements that mimic EMTALA. And we actually have a charity care requirement in that statute. The problem is our enforcement, our licensure enforcement, mostly for resource reasons, is a complaint-driven system. So if you locate a facility in an area of the state where you're not going to see an uninsured patient or a Medicaid patient, you're not likely going to generate a complaint. So really our state statute looks good on paper, but in practice, doesn't really effectively regulate this market. So I will stop there and gladly answer any questions.
I've got a question.
I'm more confused than I'm informed at this point, I think. So, Ms. Penny, go ahead.
I noticed you mentioned something about the cost of health care, and the last person that did a presentation, they showed that Georgia's cost was $1,600 and something for one night, and I didn't understand that was what it really cost, not what they charge. And Texas was like $2,000 and something. What is the average cost of a stay in the hospital in Texas compared to Georgia?
I do not have that data, but I can find that. I can tell you from that was interesting, and I do not doubt that Texas is higher cost. Again,
well, what is included in cost? I mean, I'm just a layperson. What is the federal government definition of what goes into the cost?
Well, there's a whole cost report that we submit to the federal government.
So it's just sort of random, is it?
Well, it's very defined on what goes in there, but I'm not sure on those figures. I mean, what we generally say in Texas is we're going to be higher cost because, again, we're number one, unfortunately not in football, but in the number of uninsured. We've got more uncompensated care.
I understand that.
We got a $2 billion Medicaid shortfall. So and probably higher labor cost. So all of that gets factored in and results in a higher, either a higher cost of stay, which I will see if I can produce that data.
Well, when you take the cost, just in a business standpoint, if I was going to make some money, I'd charge 50%. Is it double the cost that you charge a person?
It depends on the facility because, again, the
on
payer
the
mix.
Insurance you're getting?
the payer mix is very
Yeah.
different depending on where you are in the state.
Okay, thank you.
Can I ask you, John, on what you handed us out, it's kind of interesting to look at the independent emergency center versus the hospital emergency centers. What was the thinking on not requiring the independents to be part of the healthcare safety net, even though they're required to be open 7 days a week, 24 hours a day, not requiring them to comply with EMTALA, and then, of course, that means that you're not eligible for Medicaid as a provider. But to me, it doesn't make a whole lot of sense if you're going to have an independent emergency center, not to make it part of the safety net, and then secondhand, not to make it required to follow EMTALA as well, even though it's affiliated with a hospital. It's got a transfer agreement according to this document, has a transfer agreement to a tertiary center. What was the thinking? Was that part of a deal somehow to open the door, or what?
Yeah, I think it was a compromise. I mean, obviously, since these facilities don't take Medicaid and Medicare, they can't technically be subject to the federal requirements. So again, I mentioned we tried to mimic as much of that as we could, mimic the federal law and state statute, but again, that's always a negotiating process as well. Requiring them to be a part of the safety net, again, we don't have a charity care standard. We have a standard community benefit standard for not-for-profit hospitals, but we don't have a standard for other facilities. So really the only way you can require them to do that is to ensure that they take all comers. And I think the reality is, since they're located in areas where they're not going to see a more diverse patient mix, they effectively don't participate in the safety net. And the other thing that happens that I didn't mention is, even though they're technically part of the EMS system in their communities, the ambulances don't take patients there because, particularly more complex patients, because they know they're likely going to have to go get them again and take them somewhere that can really do the job.
So let me make sure I'm understanding too. You're saying that you're not seeing these happen in rural areas. You're seeing this more in the urban area. Okay.
Correct.
I think Rick came on first. All right, Sharon.
Confused like Terry was, and I just want to get this straight. It's not that you're against freestanding surgical centers. Apparently the ones run by the hospital you think are okay. I mean, and are you saying that the whole problem with this and not having the regulations on them is because you have no CON? Because, I mean, some people would like to see CON, I think, go completely. I don't think that's what's going to happen. So if we just tweak ours and stuff, we would still be able to put regulations on them, like they have to pay the Medicaid. So are you blaming your problems on CON, or could you have the state put regulations on them?
Yeah, no, I don't necessarily have a solution. This has been a challenge. I think we were I was just putting this out there to say these are kind of some of the unintended consequences that can happen when you tweak these laws.
So you're saying that it's because you have no CON?
It's allowed these to proliferate, clearly. But the challenge is, and this is y'all's challenge, is creating a system where in some areas of the state they can appropriately be developed because they are actually increasing access to care and lowering cost. That's what we've struggled with. Obviously, we're not going to go back to CON. We've chosen to go more the route of, as you can see in there, increased transparency. We have a mediation process now for out-of-network bills. So I didn't answer your question, but that's the conundrum that we're all in.
Okay, so Texas could have in there, before they open these up or let them come in, they could have put, even though you don't have a CON, they could have put some of the regulations on them, like you have to qualify for Medicaid and Medicare to open and this kind of thing.
Right. Or we could have just not allowed non-hospital affiliated we could have not created that license status.
Okay.
Chairman here, just had a question. So, everybody else has had maps of
Yes.
service. And I think following Chairman England's question, I'd love to see a map of, Texas showing underserved areas and served areas where these freestanding medical center or emergency centers are. I think we'd see, or am I right, that you would see them in the urban areas, suburban areas, but not really helping rural service?
Yes, and we've got that map. I can get that to you guys.
Well, I guess my question here is, why'd you do that? Because I guess it's a free market thing, and you had pressures of doing it, but you're not meeting the needs of Texans all across the state, but just in those rural areas. And in the bottom corner, you talk about, I know it's not your fault. I mean, you're not in the legislature, but that's robbing doctors and nurses from these areas to fulfill those. It seems like you all may be doing something similar to what we're doing, yet trying to figure out how you get that care in those underserved areas.
Yeah, no, I think if we had it to do over again, we wouldn't have done it. And actually, many of the members of the legislature who voted for this because they thought it would increase access are wishing that we hadn't let that genie out of the bottle, if you will.
Okay.
Darlene.
Thank you, Mr. Chairman. I want to get to help Penny out, and it does affect what we're talking about in access and cost. When you get a hospital bill, it's very broadly in two categories: room and board and ancillary charges. The room and board varies from hospital to hospital where you're located. That is for your bed and your skilled nursing. It's for your care on a daily basis. The ancillary charges are going to be whatever aspirins, medication, services that you get. So it's very difficult to use that set amount. You don't know what the charge for an MRI or an x-ray is. Every hospital's different. That's why a cost for an aspirin is $5 here and $20 there. It's very difficult, and that's why that number has to be a little bit misleading. Traditionally, that's the way hospital billed. You are now seeing them billed by DRGs, where they will bundle it and say, okay, I will give you a contract that says we'll charge you $1,000 a day for just a sickness, not a surgery. If you have surgery, depends on the type of surgery, it'll have a code, an allowance, and it'll be all-encompassing. And that's, again, these numbers somewhat are misleading because it depends very much on what services you are getting. And that has an effect on our CON. The hospitals that can do more surgery, more expensive, they'll have higher rates. And because it's more ancillary charges, they may have a higher room rate. I find that it's a big step to say this, but usually it's a little bit more expensive because real estate's more expensive in Atlanta. So your room rate's probably going to be higher there than it would be down in Thomasville. Those are the type of things that make up that difference. And you're right to be a little suspect of those numbers because it was a little bit too broad. Thank you.
Okay. We're bumping up against time post. We've got a couple more questions
Yeah.
ahead, and then Jason.
Thank you, Mr. Chairman. And I just want to remind the committee that you just said that you think if the legislature had to do it over again, they may not because rural areas wasn't served?
Correct.
Because a lot of people talk about rural, and then I'm kind of like, give us a model that shows us you're actually going to do it. Anyway, my question is, what is the community benefit requirement that you have to have, A, and B, how do you enforce it?
So we actually have, Texas probably has the most prescriptive community benefit requirement. So it's a state statute only for not-for-profit facilities. And so basically it requires, it's a 5% standard, but it's 4% in real charity care, uncompensated care. You can include your Medicaid shortfall in there, in bad debt. And then you can add another 1% on community benefit, so things that you're doing out in the community. And our state Department of Health Services promulgates rules that specify what that is. And so they have to report, the not-for-profit hospitals have to report that annually to the state, and they audit those numbers. And if you don't meet that, you can lose your not-for-profit status.
And I just want to think outside the box. You got 345. How many of those are actually, is that 345 separate owners?
No,
No.
no. A lot of those are
that have
yeah,
done,
yeah.
exactly. How many different owners would you say you had out of those 345?
Probably 15, maybe.
Okay.
The preponderance.
So it's 15 with them building, for lack of a better way of putting it, monopolies. Has Texas considered taking those 15 and say, for your community benefit, you must put one of these in an underserved area of Texas?
We have not considered that.
I mean, that would be a community benefit to the rest of the state, would it not?
It would.
Thank you.
Jason.
Thank you, Mr. Chairman. I just, on the part where you referenced the balanced billing rules, and so Texas has a mediation process, and that's handled through Department of Insurance.
Correct.
So we're struggling with that same issue. How well has that worked as far as the mediate? Do you have a backlog, or is it working?
You know, it's actually worked pretty well. The reality is most claims never go to actual mediation. Once the patient initiates the process, the provider and the health plan come together and come up with some usual and customary type charge. So it's actually worked pretty well. Now, we'll have better data going into this session, because last session we lowered the threshold to $500 and made it apply to all providers.
So it's a new program.
Well, it initially was 1,000 and only applied to hospital-based physicians.
Gotcha.
So, but that was working very well, and so the legislature said, let's move it to 500 and make it apply to everybody.
Gotcha. Thank you.
All right. John, thank you for being with us.
Thanks for having me.
All right, our next presenters are Gina Lee and Kenny Hancock, and they are with Legacy Sports Institute. Gina is a physical therapist and a certified athletic trainer who received her master's degree in physical therapy from the University of Mississippi Medical Center. And Kenny has more than 30 years of executive experience in the healthcare industry. And they're going to talk to us about this facility in Alpharetta, Georgia, and some of the issues dealing with CON that they have faced. So welcome, and tell us your story.
High-performance people, winners. What do they do? How do they do it? People in all walks of life, people in the military, people in government, world-class athletes, great coaches. What do they do when they're at their best? Now, I'm not an expert. I'm simply a conduit for this information. The only difference between you and I is I thought about these things a little bit more than you have. It's my intention this evening to hold up for you a mirror. A mirror that you can look into and examine for yourself the breadth and the depth of your goals, and the commitment and the discipline and the perseverance you bring to the pursuit of those goals. It's my intention this evening to create within you a little dissonance, a little disharmony, a little dissatisfaction, which is the essence of motivation. So for the balance of the evening, you begin to ask yourself some hard questions. And maybe you'll be satisfied with the answers, and maybe you won't.
You ask us to be honest, to be transparent, to be very direct, very blunt, and to tell the truth. I am not a licensed lobbyist. I am not a CEO of a hospital. I'm not an attorney. I'm not a doctor. I'm not a director of a medical association. And I'm definitely not a CON expert. I am the daughter of a high school coach from Mississippi and a 36-year kindergarten teacher. Grew up in Tylertown, Mississippi, population less than 1,500. My partner in this is the world-renowned sports surgeon, Dr. James Andrews, born and raised in Homer, Louisiana, population less than 3,000. 45 years ago, he came to this great state, to Columbus, Georgia, to begin his successful career with Dr. Jack Houston at the Houston Clinic. We truly appreciate the values that we learned growing up in small towns, and that has truly been the foundation of our careers and our plans for Legacy Sports Institute in the state of Georgia. Sorry. Our journey together began 18 years ago when I began my training and career in physical therapy in Birmingham, Alabama. And through those experiences and working with some of the best athletes in the world, traveling throughout, seeing some of the best healthcare facilities and sports facilities, we developed a vision that would bring together all the quality aspects, focusing on research, education, innovation, true world-class experts at a facility in the state where Dr. Andrews began his career. And while implementing all these on a campus that would truly be able to provide a global platform for research, education, and innovation, while implementing so many core programs that have allowed Dr. Andrews' career to be so successful. A huge part of this campus plan, a 30-acre campus in Alpharetta, Georgia, is an entirely nonprofit foundation that we will operate on a $5 to $7 million budget a year, that we raise and provide the funding for that. And that is through personal donation of many of our athletes, our professional sports organizations throughout the world that are looking for ways to give back and to promote safety and healthcare advancement in our world. One of those key components is our doctor training program. Dr. Andrews has trained over 400 doctors in his career and currently takes 4 orthopedic doctors and 2 primary care doctors that are very interested in learning more and really being specific in sports medicine. So we fund a fellowship program where we take 6 doctors a year, and usually the ultimate goal and results of that are obviously more specific training in sports medicine, but in helping to recruit doctors and retain those doctors in that state, which Dr. Andrews is very excited about giving back to the state. The innovation side of this is bringing academic components, medical schools, products, global brands, healthcare professionals throughout all the hospital systems, throughout all the organizations, and working together to develop some of the most innovative products and healthcare research in the world. Our education platform, we currently have over 500 education events that we host, and we'll do that same thing in the state of Georgia. And people from all over the world. Dr. Andrews has been one of the leaders and founders of most of those organizations, but it allows doctors throughout the state, healthcare professionals, sports specific professionals to all have a true global platform to educate the world on what can make sports and healthcare better. A unique policy Dr. Andrews has always provided is that we never turn away a high school athlete, no matter what state, where you're from, whether you have insurance or you do not have insurance. That is provided by us at no cost for those high school athletes that do not have insurance. And not only in our CON application did we present and commit to 5% of the indigent care, we also committed to implement this policy in the state of Georgia as well. And it's not just in the surgery center aspect, it's also through the therapy and braces that they would need to return to play, and all of that cost adds up, but it's something that we have always committed to do and will commit to do in this state. We also have an entire portion that is just military programs. So we work very closely with our state and even at the federal level. And Dr. Andrews will say it's probably one of his most proud moments. A few years ago, we did a program in the state of Florida where we took the orthopedically injured military special ops athletes and intertwined them with the professional athlete. And he will be the first to tell you the athlete and himself and the rest of us were the most inspired by being able to be a part of those military programs, especially in your state and at the federal level as well. So, October the 7th, I gave Dr. Andrews a call, 2014, and I said, I know this is a last wish for you, a last dream, and we've got some of the best people in the world to help implement this in your home state where your career started, and just wanted to let you know we're beginning this journey. And he said to me, Gina, it would be a dream come true. There is no doubt with the talent that the state of Georgia has, meaning in healthcare, your academic institutes, your medical schools, your international airport, your pro sports teams, your great college, your enthusiasm for sports and sports medicine. There is no doubt if we work with the leadership of the state of Georgia, all the healthcare hospitals, private practices, all these people together, we can help lead the way to make Georgia the sports and sports medicine mecca of the world. And I am 100% committed to doing that. And so, with a lot of excitement, the next morning as he's walking into the operating room, he calls and says, the first thing we need is a CON. And the reason being is because I want to have doctors. I have 45 in Georgia that have trained under me over the years, and I want them to be able to be involved in research and education and get in that operating room with me and help learn to develop their own fellowship programs at their hospitals and their practices throughout the state of Georgia. And darn, that means we got to work on a CON. Well, I didn't want to let him know. I didn't know what a CON was. Believe me, I quickly found out. We developed our team and really got to work January 1 of 2015. And miraculously, in just a few months, this was our first application for a CON. So I wanted you to have an idea. It is over 1,000 pages long. You basically have to build the facility, even though we were only requesting 4 operating rooms for an ambulatory surgery center. And it takes a team. It takes a lot of work, a lot of money, a lot of time to be able to do that. During that time, we contacted all of those doctors, the local hospitals around the Atlanta, Alpharetta area, people that we knew were very passionate about health care, and let them know we are pursuing a CON so that we can advance health care in the state of Georgia. We can focus on research, innovation, and education. It is not about a revenue stream. It is not to compete with anybody. It is to truly bring world-class services and help this entire state advance. And excited, we obtained the CON from the experts at DCH in September, and with great disappointment, within a month, almost every hospital around the Atlanta area had opposed us. And so we, again, disappointed but understood, and we went and met back with all of these hospital administrators. And most everyone backed off and said, we understand. We didn't know if we could be included or not, and we were very transparent that, yes, you can. But we had one specific opposition that said, By no means. We either want 100% control and 51% ownership, or we will take you to the Supreme Court, and Dr. Andrews will probably be dead by the time you're able to obtain a CON. Confused. I mean, again, a man that has meant everything to the profession of sports medicine, what do you do at that point? And so we tried to justify that response to us on really trying to help this entire state. And so we looked at just some data. Why would our opposition be so adamant when they own several CONs in that area, but they do 0 cases of orthopedics, 0 cases that we had proposed in our plan for a CON? How could you justify that you are opposing us and that adamant about it? Never really got an answer on why that was. We continued to focus, as Ms. King explained, the next step for us was going through a court hearing, which was scheduled in March of 2016. So they gave you plenty of time to wait and prepare for that, and we did. And leading up until that point, the Friday before the court hearing started, I had a contract with a hospital in the Atlanta area where a great relationship, had been there several years, where I brought in the professional athlete referrals and was able to treat those athletes there and help promote their sports medicine program. Very transparent with them for many, many years that this was the ultimate goal for me to give back to the state of Georgia and to the legacy of Dr. Andrews. And I walked in on the Friday morning before our court hearing started, and I was told with a tissue box from my administrators that because our opposition had a letter of intent to acquire the hospital system that I had an agreement with, that I had 2 choices. I could either withdraw my CON application and walk away and never pursue building this world-class facility, or I could be out by 5 and never step on that campus again. With no hesitation, I said, I'll be out by 5. Our court hearing ends up, I'm not sure exactly, but we've been told that that really was one of the longest court hearings for a CON case. We had 6 days of testimony, hundreds of people that offered to come and testify on behalf of this being such a value to the state of Georgia. And the court hearing officer narrowed that down to 18. We had global letters of support, and we were told that through our opposition that this was not needed in the state of Georgia. The state of Georgia was already #1 in health care. They were already doing everything that we were going to do, and by no means were we welcome in this state. And at the end of that court hearing, Dr. Andrews testified, and he said, you know, I've been hearing what's been said the last few days during this court hearing, and it's really hurtful, and you should be ashamed of yourself to represent a state with such great citizens and with such great talented people that are very passionate and understand what having to work hard and overcome obstacles and be perseverance in everything we do, that this would be the character that you would present to represent this state. And they seem to continue to call him nothing but a glorified marketer, and I'll let you be the judge that this is his resume, 175 pages. He has taught around the world. He has written every sports medicine book there is to imagine. He has taught doctors from all over the world, and to be treated, I'm protective of him, and to be treated that way was again another disappointment. Unfortunately, shortly after that, I think I'm mixed up on some slides, but shortly after that we found out that the hearing officer reversed the experts at DCH, and then it was reinstated by DCH in August of 2016, and we thought finally this challenging journey is over. But unfortunately, then our opposition filed a lawsuit to appeal DCH's decision. So after many times of our opposition reaching out and wanting to just talk about how they can be involved, we were very honest. This is not about the money. We want everyone, and if we just choose one hospital to align with, it would not be our best way of giving back to the entire state. And so we agreed to have another in-person meeting this was probably the fourth or fifth time over the first few years. And I was directly told that we will spend every bit of your money. We have more money than you will ever have, and we will utilize that to make sure that this facility is not built in Georgia. And so I hope that you're worn down. We hope that you give up, because that's your only option to be in the state of Georgia. I tried to take the higher road, as we have throughout our career and throughout this journey, and it's very difficult, to be very honest and transparent with you. But I got home and I thought, there's got to be something that Dr. Andrews and I and our team are missing. You know, what is it? Are they really the best hospital in the world? Are they really number one? I searched. I must have spent 3 or 4 hours. I Google best doctor in the world. I see Dr. James Andrews come up everywhere. I look for number one hospitals in the world, number one hospitals in Georgia, and this seems to be all I can find. And to me, mediocre is not the best standard. And so I said, well, maybe I know they don't have a sports medicine program, and we're not competition to them. We're not affecting their bottom line. So maybe it's orthopedics. And I specifically look at orthopedics, and this is what I find. 35.1 out of 100, yet your patient volume is high. Of course you are. You've told me that you are the CON police for the entire state of Georgia. Your volume's going to be high, even though you don't do any orthopedics. So we continued on, not giving up. Superior Court, just a few weeks after that, reverses our CON decision. Then the Court of Appeals sustains the Superior Court's decision. And then on February the 15th, we are at the Capitol with some support of Representative Chuck Martin and Senator John Albers, believing in our project and the value that this would bring to the state of Georgia. And it was a very educational experience for us, and at least allowed us to be a voice and let everyone know that what we were trying to bring to the state of Georgia. Unfortunately, we didn't make it through the Rules Committee and actually get a vote, but again, it allowed us to at least let you leaders know what we were trying to bring to Georgia. I needed a little break after that experience and decided to drive home to Mississippi, and I got an interesting phone call on my way home from a global brand representative. Had been floating around the Capitol, and I guess they do that in most states. And she just said, I have a few questions for you. Why does the state of Georgia not want you? Why are you having such a difficult time? Why is health care such a really hostile environment? We really noticed that, and we're in most states. In Georgia, it really seems to be very difficult. And I was very positive, and I said, you know, everybody has a job to do. They're protecting their territory, and if you've heard of a CON law, that's what a lot of this is about. And she said, well, why don't you just go to another state that doesn't have a CON? Why would you keep going through this? And as I drove that 6.5-hour drive, I thought, when you're fighting for purpose and you're fighting to bring a true center of excellence, and a man's legacy that has meant so much to me and athletes all over the world and other healthcare professionals. You don't just give up. So many of the athletes we have, and I don't have time to tell you all the great stories, but so many that a lot of you don't even realize are right here in the state of Georgia. The day that my opposition gave me a choice to either stop the pursuit of this facility or be out by 5, this guy was waiting in the next room for me to help him fulfill a dream. As an 18-year-old, very talented baseball player, he gave up an opportunity to go in the Major League Baseball draft. Decided to go to the Naval Academy. Even after that adventure, had an opportunity to again go in the Major League Baseball draft, but instead decided to serve our country, for me, for you, and for the United States of America. And for me to walk in there and even remotely think of giving up a pursuit so that a young man like that could have an opportunity for the best quality of care and to fulfill his dreams would not be right. These guys, all throughout this process, they're what kept me going. They are the reason that we all should stand together and fight for the best quality of care for all the citizens of this state, no matter if you play baseball or football, but truly to give people an opportunity to fulfill their dreams. I know you all know this guy, and to hear him testify at our court hearing about having to go out of state over 25 times and to want to be a part of a facility like this to where he can help promote and prevent the epidemic of sports injuries, which Georgia is one of the leading for, it is very, very impactful to know that the voice and the power together that this state could have for so many wonderful causes. And for kids like this who have a dream of playing at collegiate sports in the state of Georgia and just want to come back and be with their family and stay in this state, and they say, my dream is to work at Legacy Sports Institute in biomedical engineering and physical therapy, because we want to be at the best place in the world, but most importantly, we want to stay in the state of Georgia and be close to our family. Whoops. Whoa. Will it go back? Yeah, it won't. Because I think some of you would want, yeah, sorry. If you'll just go back to that. And then our slide with some of our supporters that I know have a special tie to Georgia as well. Yeah, no, you're right. And when those guys are calling you and emailing and texting and saying, don't give up, boy, it's a little intimidating. So make sure to keep fighting for them and what they want to do to give back to the state of Georgia and the young kids here that have dreams of becoming just like they are. I'm having trouble with this. Sorry. There we go. And then August the 27th, we found out that our CON process in almost 4 years and almost $3 million, global support, being approved twice by DCH and those experts, our process was over. The Supreme Court had decided that they would not hear our case. And so, again, very disappointing and a little bit ironic that 3 days later our opposition announces that they are going to start a big sports medicine program, which actually we truly support because that's who we are. But taking doctors away from rural hospitals and trying to bully and just buy out all the other practices or small hospitals is not what I call developing new research, education, and innovation for the state of Georgia. And so, as always, God sends me a sign of why you continue to push forward on something with such purpose. And I got a call from a parent, and actually I don't even know what town, she did not say, because she said it's so small you've probably never heard of it. but my family, we live in a small town in South Georgia, and my son's a very talented baseball player, and unfortunately, a year and a half ago, suffered from a severe concussion. We just dropped him off at college, and my husband and I are in a tremendous panic because our child is suffering from secondary effects that are causing suicidal thoughts. And could you please tell me when Legacy Sports Institute is going to open so that you can help implement education and teaching into the rural areas of Georgia and help support us so that our kids have a fair chance at opportunities, and most importantly, I'm not burying my young child who should be in the prime of his life because he doesn't have accessibility or the best quality care in the world. And I said, yes, ma'am, I'm not going to give up on this state, and I won't give up on your son. I will close by saying everything in my career and my life has been about teamwork, and it takes teamwork to win. And I want to reassure you, there are people that are best in the world in healthcare that are truly passionate about giving back and supporting and being involved with all the needed items, which are education, research, and innovation, to do better, to be better, to win. And that's what's going to take. It's going to take working together and creating an environment with a lot less hostility, a lot less bullies, and a lot less horrible atmosphere for people to really thrive and succeed and work together. And I'm very thankful that I've had the best team to work with. And one of those members is Kenny Hancock.
Thank you, Gina. Wow, that picture right there. See what happens when you get involved with a project like this? You lose all your hair and you gain 20 pounds. Hey, there's nothing wrong with that. I'm just saying, right? So when I met Gina almost 4 years ago, what she just said to you is exactly what she said to me. And I thought at the time, boy, that's a broad vision, and that's something that may not be attainable. My background has been in ambulatory surgery since the mid-'90s, and I was invited to discuss the surgery center with Gina and her team. The relevance that I had to Georgia was in the mid-'90s, I went to work with Resurgence Orthopedics. At that time, there were an 11-person group. We grew that practice to over 70 doctors in the time that we were affiliated with them, and built out 5 facilities around the city of Atlanta. And we used the letter of non-reviewability process for the surgery centers. And the reason that's relevant here is the reason we didn't use the letter of non-reviewability to do this project in the first place was because this was going to be an all-star campus. And unique to any project that I've ever been involved with, we had met with what were competitive orthopedic groups in the city of Atlanta. And those competitive orthopedic groups had a desire to come together on this campus. And that is very unique because they compete in the marketplace, but yet they saw the merits of the comprehensive nature of this campus, so they wanted to be part of the campus. And so in order to be able to take advantage of their interest in this project, we needed a surgery center that had a certificate of need so that we could bring everybody together from a research, education, training, collaborative perspective. So that's the reason we chose not to take the LNR path. We chose the CON path. I advised them that it would be very difficult. My experience has been over the last 25 years or so, I've probably done 40+ projects, and 10 of those in CON states and the balance in non-CON states. So I understand the complexity and the challenges of getting through the CON process. I was going to take you through just the technical aspects of the process, but I think Gina did a nice job with that, so I just want to give you my observations today. The project vision for this was a comprehensive sports medicine campus, and I would say that that's remained intact from the very beginning. And if anything, I think that has grown in scope. I've had numerous meetings with Gina, with professional athletes, with college athletes, with parents, with people from industry that are interested in the collaborative nature of this project. And so really every aspect of sports medicine that you can imagine, I've had an opportunity to hear them personally, hear what their challenges are, and listen to them espouse the merits of a campus like this. Something like this just doesn't exist in the United States. So as I think there is a definite need here, and it's been identified by Gina and by Dr. Andrews. It's been corroborated by those that I've talked to from a professional and college perspective. And I think it goes all the way down. It goes down to high school, it goes down to youth. And then you get into youth prevention of injury, and that's a major passion for Dr. Andrews. I will say this battle has been brutal, especially if you're somebody without a business background like Gina. She comes from a clinical background. She was very naive when we started this project. She had no idea the challenges that would be in front of her. But there's more enthusiasm for this project today than ever before. And I will say that we've allowed the certificate of need to drive this project and to keep the realization of the project at bay. And if you think about it, surgery is just one aspect of this comprehensive puzzle. Yet we had to follow the process to see if we could deliver surgery in a fashion that made sense for this campus. Now that we know that that's not a possibility, it is not going to stop us. And we've had numerous meetings over the course of the last 6 weeks. We have a very consolidated team that want to come together. And we'll pursue the letter of non-reviewability where we have to with independent groups. We'll lose some elements of training and research and education and the collaboration, but so be it. It will allow the campus to come together. I will say this, had she chosen a non-CON state, this would be open. Had we been in Texas, this would be open. And then just a couple of notes, because my background is in ambulatory surgery. The cost of a freestanding ASC from a reimbursement perspective, and this is relevant to you guys, it's 45% lower than a hospital outpatient department, 45%. This would have met that criteria. And you can go to association.org and you'll see the information that I'm about to tell you. But there's 5,300 ambulatory surgery centers, all 50 states of the United States. Over 7 million procedures are done annually. On average, Medicare saves $2.3 billion a year when those surgeries are done in a freestanding setting versus a hospital outpatient department. And the patient co-payments are also lower. HSS has come out with a study. $7.5 billion can be saved by Medicare, was saved by Medicare from 2008 to 2011. And that same study projects that almost $60 billion will be saved over the next 10 years. So there's more to it than just the comprehensive nature of this. It's about cost. It's about, from Gina's perspective, us taking care of not only those that can pay, but those that couldn't pay. So that's it for my comments.
Okay, Ed?
Thank you, and thank you. I don't know if either one of you know this, but, or can help me with this. House Bill 974 was in the Governmental Affairs Committee, as were some others, and we granted a hearing, and I want to say, you showed a slide that said phone call March 2018. I frankly don't know if it was related or not, but I was confused as chairman of that committee with granting y'all a hearing, and then at the last minute, you didn't want the hearing. And do you know why?
I'm not.
So it wasn't a matter of getting to rules. We were looking at trying to help and had made a commitment to some folks that we wouldn't let it be an attachment bill that we hear so much about.
And we did pass through the, I'm sorry, so it's not my specialty. We passed through one of the House committees that would have then gotten us to the Rules Committee. So we did actually pass through.
No, okay. I just know Chuck Martin, it's
Yes.
Chuck Martin's bill, and I think
Yes.
Raffensperger,
Yes.
I want to say, was the other supporter
Correct.
of it. And all I know is that we granted you a hearing, and at the very last minute, Something happened.
You're correct. That was our very first hearing. There was so much animosity, similar to you've heard someone speak on behalf.
And I just felt that we should have, so we
Yeah.
had a chance to help you negotiate it. Maybe you
Right.
didn't, maybe it's the same as we heard from Dave earlier.
It was.
But we were preparing to move forward and let people know there
And
won't
you're
be
right.
amendments, it won't be a vehicle, things of this nature. So I was just curious of why y'all decided not to have the,
Same thing. Just,
Okay.
Just
okay, thank you, Mr. Chairman.
Anybody else? Matt?
I just have a statement.
yes.
And it's, to me, it's a sad day for the citizens of Georgia and our patients in Georgia when a nonprofit entity with $350 million in reserves in 2017 used those reserves and other monies to fight you.
Yeah.
How much in reserve?
350 million.
Could I ask a question? Can you get a hold of that? Robert? Thank you, Mr. Chairman. On what basis did a Superior Court judge reverse DCH commissioner, or is that part of what, I mean, explain that little caveat to me, please. Is that?
You're talking about the Superior Court?
Superior Court, I'm sorry.
Yeah, I think the Superior Court just ruled that the state, that their decision was incorrect. And that decision was not made on numerical need. Rachel talked a little bit about that yesterday. It was made on an atypical barrier perspective. What the atypical barrier does is it looks at a number of parameters: cost, quality, access to patient care. And the state felt that barrier had not been met, particularly as it related to professional athletes. The judge just simply disagreed with the state, and he ruled that the atypical barrier criteria as such was used was incorrect.
Anybody else? Dominic?
Thank you for your presentation, but I believe one of the last comments that Mr. Hancock made was that we would serve patients that can pay and those that cannot pay.
That's correct.
And one of the things that I've heard for years is one of the major concerns is with this type of a facility or access to health care is, well, you've got to serve some of that, I guess, indigent population or the ones that can't pay. When you made that statement, what does that mean? Is it you serve a certain percentage of those that cannot pay, or just any of them that cannot pay, or give me a more
Well,
clear
the
picture
CON
of that.
requires 3%, and we elected to elevate that to 5%. And so we were subject to an audit that on the total volume that center was doing, that 5% of that would be, charity care or indigent care basis.
On that 3%, one of the concerns that I have had as a legislator is, are you still cherry picking that 3%? Are you kind of deciding, well, that's one that'll be a little easier, maybe a little simpler, we can do that one, and it'll also count towards our 3%, or are you just taking them first come, first serve?
I think you're taking them first come, first serve. Gina can answer that, but I mean, in her experience with Dr. Andrews, they've never denied any patient access because of their inability to pay.
Dr. Andrews will tell you the best pay is seeing those kids that would have not had those options to have surgery or have care, be productive citizens and move forward with their life, and that's the best pay that we would ask for.
Thank you, Mr. Chairman. Thank you for your presentation. I guess my question is really relating more to the laws of CON. So it's my understanding one health agency was able to stop this whole process, and all the others that you communicated with was somewhat on board with your plans to bring Legacy Hospital into Georgia?
Well, it was Ambulatory Surgery Center, which is a component piece to Legacy Sports Institute. And, everything was followed according to statute, and we had multiple hospitals that were in opposition to us initially. A number of those dropped by the wayside, and at the end, we had a couple of hospital systems that were opposed to us. We met with them intermittently through the process at their call, and we were unsuccessful in terms of being able to negotiate something that made sense. So that's just the way the process works. You know, it played out as according to statute.
Okay. Thank you.
Sure.
Thank you. I just want to let the committee know that when we went back and changed CON in 2008, one of the factors that led us to that was that Dr. Andrews, the Houston clinic, had wanted to do a hospital that specialized in orthopedics in Columbus, and had tried to go through the process and could not get it okayed. And so they went across over into Alabama and bought a hospital. And our Georgia patients had to go across into another state. And I will tell you that Dr. Andrews at the Houston, in case you don't know, has been nationally recognized for the work they do. If I'm not mistaken, they came up, and I've had 2 knee surgeries, with the way that they check you to make absolutely sure that the knee replacement they put in is the right knee replacement for the size of your knee. And this is all done through a special electronic thing. And they are just the outstanding place in, you know, the country to sort of go for orthopedics. Not that the other places aren't good, and we don't have good orthopedic doctors like Deborah Silcox and Beth Beskin's husbands, 2 of our members, but they are just really great, and we did lose that hospital. And it would have been jobs, income, and ease, and quality care for the patients of Georgia, and we lost it to Alabama.
Yeah. Or Penny.
Okay, Penny?
I guess I'm still stuck on this $300 million in reserve. There used to be a lot of talk about money being put in banks in Georgia. Is this $300 million offshore, or is it in a Georgia bank? Thank you.
Rick?
Yep. Thank you, Mr. Chairman. And on what I heard, just to make sure from Gina, you made it sound like there was one healthcare system that was in opposition. I think Kenny made me think that there were multiple. Which one is it?
So initially, there were multiple, and that's not unusual. And then as we had meetings with the various systems, all but 2 dropped from that opposition as we proceeded through the process.
Yeah, so there still were more than one. I think you really made a point of it being just one.
There was one that was principally the leader here, and then the secondary system maintained their opposition to it. So,
Well, thank you.
but everyone else dropped. So
Okay. Well, the other question was, so Kenny, did you say that this moment now you're doing the LNR, you're not pursuing this major project? Is that what I understood?
we will pursue the major project. Right now, the only option we have if we're going to provide surgery on that campus is through an LNR process. We've had discussions with the orthopedic groups that are interested in being on the campus, and that we'll take that step if necessary.
Okay, thank you.
Yeah.
Any other questions? Clay?
I think your last statement is a shame. I hate that went down like it is. But as the House Rural Development Council, and we're looking at rural issues as well, I did want to make mention that that this does have an immediate impact on training our rural docs. In fact, I had 2 rural docs call me regarding Representative Chuck Martin's bill that you referenced, greatly encouraging me to support that measure because of what it could do in advancing not just information for athletes in rural parts of the state, but providing an information base and training for the docs in different hospitals in different areas throughout the state. And I appreciate your resolve in that, and I'm sorry.
Patty? Do you have a question?
Well, Mr. Chairman, I just have more of a comment. I just think about all the presentations that we've heard thus far, and I know everyone in the room is aware of the situation with my husband, car accident, and having to spend the entire summer at the Shepherd Center. And I think about if the Shepherd Center had came along before CON was created, I probably would had to go outside the state of Georgia for those services. And so I'm very grateful that the Shepherd Center is here in Georgia, and I was able to stay in Georgia and get those services that my husband so desperately need. And because of the Shepherd Center, when we go back in session in January, my husband will return to the Shepherd Center, so I won't have to worry about him being down in Taylor County while I'm serving the people of Georgia at the state capitol. So it was just more of a comment, just thinking about the Shepherd Center and the things that you had to go through. So thank you again for your presentation.
And thank you for comparing us. Georgia is so, blessed to have the Shepherd Center. And I think it really sets a precedent when you really provide a world-class service. It truly is a compliment, and it affects the lives of every citizen in the state, whether you are providing health care services or whether you are receiving them. And by working together with that world class, just like the Shepherd Center, it's an immediate impact that changes the lives of every single person in this state. So thank you.
All right, any other questions? Last question.
I just remember back when this was discussed back in the session, I have an athletic trainer that worked in Alabama. Now, what do y'all do for them? I think y'all, the Houston Clinic, does something real special. I just remembered this a moment ago.
Good question. So through our nonprofit foundation, which again, we operate on a $5 to $7 million a year, and because of limited time, I'd love to talk to you more about ways that you can help set a precedent for the entire United States on so many of these programs. What we did in the state of Alabama, and we would commit here as well, is we actually funded over 135 athletic trainers at our expense for every high school in the state of Alabama, so that those kids in the rural areas and those families and coaches are protected and served through health care. And we did that, again, out of our pocket and our heart to make sure that those kids had some type of emergency medical services at their high schools.
Thank y'all very much.
Thank you.
Your turn.
All right, our next presenters, just before our lunch break, and our lunch break for members of the committee and staff will be in the room directly behind me for the members of the council and staff. And we'll do that as soon as we finish with this next presentation. And we've got Ray Williams, Cash Trivedi, and Dr. Alan Yohanda with Cancer Treatment Centers of America. I'll get the words to go along with the letters right here in just a second. So,
Right.
Ray.
Thank you, Mr. Chairman. If it's all right, we'd like to sit at the table.
Sure.
That way we can duck easier behind the table if we need to. Thank you, Mr. Chairman. I think what I should say is just stand up and go, what she said, because Gina did a great job talking about kind of the culture that they've experienced, and we obviously have experienced that in some of the same way. So way to go, Gina, for that. Mr. Chairman, all the chairmen on the committee and members of the council. I am Ray Williams. I am a licensed lobbyist for CTCA, and with me today is Dr. Alan Yohanda, who is our chief of staff and a surgical oncologist at the hospital in Noonan. We certainly appreciate the opportunity to present to you this morning. We do recognize that we are the only thing standing between you and lunch. So we'll try to be as brief and concise as we can be. And we really, really appreciate this council taking a look not only at our particular issue relative to CON, but the CON issue in general. It certainly has been said many times, it's time to do it, and we appreciate your courage and your willingness to take a look at this. So, all right, who's got the slide? You got it? Okay. All right, so you were also kind enough to send us 3 questions that you wanted us to answer relative to access to cancer care. And we're going to try to confine our remarks as best we can to answering those specific questions. The questions are, and you see them on the board, what changes in CON would allow more access to cancer treatment in Georgia? How do you believe these changes would positively affect cancer treatment accessibility around the state? And what would be the impact in rural and urban Georgia? So again, we're going to try to answer those questions, provide a little background information, and then provide you what we think are solutions and then the impact of those solutions. But I'd like for Dr. Yohanda to talk a little bit about the disparity in cancer care in Georgia today.
Oh, I'm sorry.
That one on? Just talk amongst yourselves for one moment.
Hello? Okay, great. The slide you have in front of you now is our data from the National Healthcare Quality and Disparities Report. This is a report that's mandated by Congress every year. It is comprised of 250 measures that broadly survey or overview the healthcare and disparities environment within the United States. The data is broken up into both national data and state data, and what you see up on the board currently is this data for the state of Georgia. Now, just to break this down for you so you understand the meaning of this graph, the colored bars are the national data, so that's from the very best being in the green to the worst being in the red. The white caret is where we stood in the state of Georgia at the baseline when the surveys were first being done. And the blue caret is that of our most recent data. So what that shows is that at our baseline, we were just average. But over time, we've become worse. And as our previous speaker said, I don't like being average. I'm being very competitive, as I'm sure you all are as well. And to be average is not good enough, but to be worse than average is even worse. So that's where we stand right now as far as the delivery of healthcare, of cancer care in the state of Georgia. Next slide are data from the American Cancer Society looking at death rates for various types of cancers, again, in the state of Georgia. According to the American Cancer Society, there will be 56,920 new cancer cases in the state of Georgia this year in 2018. And of those, and also during that year, there will be 17,730 cancer deaths in the state. What you can see from the slide, we are below average in some of the common cancers that affect the citizens of this state, including colorectal cancer, breast cancer, and especially very much below the benchmark in lung cancer. And really what's interesting about these data is that all 3 of these cancers, and in addition to another cancer, prostate cancer, are cancers in which there are well-described, well-documented, and medically or scientifically supported screening programs or screening methodologies to try to prevent many of these cancers. And that may be in part contributing to this worse than average or worse than national benchmark death rates in these cancers.
So the first question, thank you, Dr. Yohanda. The first question is what changes in CON would allow more access to cancer treatment in Georgia? And obviously we're going to, tailor our remarks around our particular situation. We don't claim to be the end-all to be-all to cancer, but for cancer treatment in Georgia, but we want to be able to play a more significant role. So just to reiterate, we are a destination cancer hospital. I will tell you that, to my knowledge, we're the only destination cancer hospital in the country. It was a product of the 2008 session. And I would acquiesce that we were asked if 65-35 would work. I will tell you, in the other states in which we operate, That is simply the ratio that we see of in-state and out-of-state. It's not mandated. It's not statutory. It is just what that experience was at that point in time in the other hospitals in which we operate. So that is kind of how that came about. We are a licensed general hospital. We do have a CON for our beds and for equipment. We are limited, as you all know, and if Cash has been doing his job for the last 2 years like he said he's been doing, you all know this already, but I believe he has been.
No
we-
what? No,
So-
no what?
Oh, man. So we are limited to 35% in Georgia, and obviously 65% must be from out of state. We have met that ratio and complied with that ratio every year that we've been in operation. If we don't meet it, it's a $2 million fine the first year, a $4 million fine the second year, $6 million fine the third year, with the possibility of having our license revoked if we don't meet that. And believe me, we have had internal discussions about just seeing everybody and not worrying about it, but we want to be a good citizen of the state of Georgia, a good community partner, and not practice civil disobedience. But it is untenable for us to have to turn people away or deny or delay care. But it is the law today, and we want to conform to that law. We can have no more than 50 beds. That is in statute. Earlier, I think someone talked about the ability to grow their beds. We don't have a path to do that. And you'll see in the solutions that we want to offer something that would allow us, if needed, and if the demand was there and the capacity was there, so that we do have a path to grow our beds. We must provide 3% indigent and charity care. We follow the rules as prescribed by the Department of Community Health, and I can tell you that our 5-year average for indigent and charity care is about 4.5%. So we have met and exceeded that ratio every year that we have been in operation. The statute also says that we must see Medicaid and Medicare patients. And again, we have provided care for both Medicaid and Medicare. Our Medicaid population admittedly started off slow, but year over year we have improved and taken on more Medicaid and Medicare recipients. Let me also say that we do have some special exemptions for equipment and services that come within our statutory definition. And I'm glad Gina mentioned some of the nonprofit work that they do. And let me just mention a couple of those that aren't on the slide. We have a program called the Assistance in Healthcare. And this is a benevolence fund that we, as stakeholders or employees at CTCA, we contribute to, and we build that fund. And what this is used for is for cancer patients and their families who are trying to meet the cost of daily living. It could be rent, it could be something else they need. And interestingly enough, they don't have to treat at CTCA. Can just be a cancer patient. And you'd be surprised at the number of discharge planners and case managers from the other hospitals in the Atlanta area who have sent their patients to us to receive funds from the Assistance in Healthcare. So we're trying to help all cancer patients, not just the ones that are being treated. In addition, the parent organization is a major contributor through our Gateway Foundation, and it is designed to help understand innovation and research in cancer care. We've given to other institutions like Duke, Stanford, and others so that we can further the advancement of cancer care. It's not just about us, it's about furthering that. Next slide. So talk a little bit about the 65-35 and what does it really mean? The chart that I hope you have in front of you, that you do, is an internal memo that is produced by our folks, and we follow this on a daily basis, a weekly basis, a monthly basis, and a yearly basis. Because at the end of the calendar year, we have to be able to demonstrate that we were in compliance with the 65-35 ratio. And we follow it every single day, every single month. And as you can see, if you look at the bottom right-hand corner, As of August, we are 2.8% over the 35%. So we have to try to address that moving forward. This is real. This is something that we have to do every day to track this ratio. Next slide, please. So what does it mean? In 2016, it meant that we had to deny or delay care to 71 Georgians. Cancer patients in Georgia, 52 in 2017. And based on where we are right now in the ratio between now and the magic number of December 31st, because the clock starts over again on January 1st, we have to deny or delay care to 90 to 100 Georgians if the ratio trends continue as we think they will. 90 to 100 Georgians who have researched, have prayed about it, have talked about it, their families have sat down and decided and determined that the specialist they need is at this hospital, but they may not be able to get in. Let me give you a couple of anecdotal situations that kind of bring it home a little bit more. We have a patient, a lady from Florida, so she's in the out-of-state ratio. She contacted us a couple weeks ago and said her husband had been offered a great new job in Georgia in the film industry. He's a sound editor, and he wanted to take this job. But they were going to turn it down because she was afraid if she moved to Georgia, she would then fall subject to the ratio. And so they weren't going to take the job. Fortunately, because she started as a Florida patient, she would remain a Florida patient for the next 36 months and fit in the out-of-state ratio where there is no restriction. But here's a family that was coming to Georgia in this industry that we're all promoting, but they weren't going to do it because of this ratio. The second example, last year during Hurricane Irma, as many hospitals were, we were contacted about could we take their patients? Could we, particularly their cancer patients? We said absolutely, we'd be willing to do that. However, we checked with the Department of Community Health and we're told, no, you can't do that because of the restrictions that you have and because at that point in time, Coweta County had not been declared one of the disaster counties and they couldn't waive our CON limitations. But here we were, ready, willing, and able to help, but not able to because of these restrictions. We've got a short video we want to show you of a patient of ours. Her name is Pam Alford, and I think she epitomizes the challenge.
When I first found out that I had cancer, ultimately I found out that it was inflammatory breast cancer. And that is probably like less than 5% of people that get that. And because it is so uncommon, you know, I started doing research trying to find the best place that I felt like that I could go for treatment. When I found out that there was a local hospital here that I could go to and that their doctors, they specialized in inflammatory breast cancer, which is what I have, I was certainly excited and knew I had found the place I wanted to go to be treated. So when I called and they told me that because I was from Georgia, that they couldn't treat me. And honestly, I was devastated. I didn't want to have to settle for something less. And I felt like that because of this law, that they were forcing me to settle for something, and I didn't want to. And not that there's not other good places, but that's where I wanted to go for my peace of mind. That's where I felt that I could get the best treatment. I'm always thinking, is this what they would have chosen? Is this what those doctors would have done? Because you always live with that fear of doing the right thing.
Now, just to give you a little context on the video, inflammatory breast cancer is an extremely rare but aggressive and deadly form of breast cancer. Probably represents about 2 to 5% of all cases of breast cancer, and it takes a very specialized center because of the multidisciplinary care that it requires to treat one of these patients. It takes a very specialized center to adequately manage those patients. And just a point of fact here that in South Georgia, it has one of the highest rates in the country for inflammatory breast cancer. Also, in rural Georgia, the death rates from breast cancer are higher than those for national average and also higher than in urban centers of the state. Also, the Centers for Disease Control, or the CDC, has published data showing that for the incidence of cancer, how often it happens, it is lower in the rural communities, but the death rates from cancer are higher in rural communities. So let me just give you a second to have that settle in. The incidence rates are lower, but the death rates are higher. And I think according to the CDC and the deputy director, Ann Sushot, the feeling is, their belief is, that it is not the geography that affects the incidence of the type of cancer, but it is the geography that will dictate or impact your opportunities to get proper screening, prevention, diagnosis, and treatment. So those are the drivers for why there's such a disparity in the death rates between rural and urban communities. Whenever I speak in front of a group such as this, just to bring it much more down to home on cancer, I always say, look to your left and look to your right. So everybody look to your left and look to your right. And one of the three of you is going to be affected by cancer at some point in your lifetime. And if that one person is you, or that person may be a loved one of yours, then you better hope and you ought to better pray that you have access, unfettered access, to skilled, comprehensive cancer care. Very similar to Representative Bentley, whose husband had the benefit of going to the Shepherd Center. For your cancer care, it is best to be done in a specialty center.
Thank you, Dr. Honda. So on the screen is the solution that we offer, and obviously this is germane to us, but let me run through it. This was what was included in Senate Bill 31 that was heard in Madam Chair Cooper's committee, carried by Chairman Hatchett. What we would recommend is that CTCA be just designated as a general hospital that specializes in cancer care. That is how we operate in the 4 other states in which we operate. We have heard no problems from the other hospitals in that state. We're not putting anybody else out of business by being a general hospital that specializes in cancer care. It is the mission, the vision, the values, and the founder of this hospital founded it to change the face of cancer in Georgia, and that's what we want to, or across the country, and that's what we want to be able to do without these restrictions. If there is CON that remains after you all make your recommendations and it works through the legislative process, then we would advocate that we work under those CON rules. So we're not out on an island as this only hospital of its type, that we're under the same rules as other hospitals. We believe, obviously, that the 65-35 should go away. It doesn't necessarily make sense to us to stagger it and do it over time, because even if it's 90 people, if it's 50 people, if it's 30 people, these are cancer patients in Georgia that need to be treated. We also would recommend a path so that we can grow beds and meet the demand that is obviously here in Georgia. Given the new number of cases that Dr. Yohanda mentioned, there's more demand, and unfortunately, for everyone to be able to be seen. We would be willing to raise our indigent and charity care to 5% to help meet the needs there. And we would obviously continue to provide Medicaid and Medicare. This frees us up, if you will, to offer some solutions relative to the effect of what this change would bring. So the next question, I guess I have to do it, there it is how do you believe these changes would affect cancer treatment accessibility around the state? Okay. And these are obvious answers that we're going to give more detail on. But obviously, it creates additional choices, creates greater access, enhanced options for specialty care like for Pam offered. It increases competition. I've always kind of lived by the motto of iron sharpens iron, and it's certainly true here. It heightens innovation. We have clinical trials going on at the hospital. We have around 90 Georgians that are currently enrolled in those clinical trials. We'd like to be able to see more Georgians, because the more folks we have participating in clinical trials helps that next person who's battling cancer, because of what we can learn through those clinical trials. And finally, it creates more collaboration. This is where I agree with Gina a little bit. We have, CTCA has had its fair share of animosity delivered against us in the state. Matter of fact, I tried to hired a former hospital administrator in the state and asked him to help us go out and build relationships with hospitals. Well, not surprisingly, no one would talk to him. Nobody wanted to, if they did, they wanted to do it in secret because they didn't want to talk to us for fear of what may happen in retaliation in the marketplace. And that's sad. So we feel your pain, Gina, that we've experienced some of that as well. We want to be able to be collaborative and be in partnerships with folks, not put anybody out of business, but just work together as we find these opportunities. Dr. Honda?
All right. What we have on this slide is sort of an outline of what we think we have to offer at CTCA, and because if we had more access to Georgia patients, and especially rural Georgia patients, what would be improved with their care. So if this sounds like a bit of an advertisement for CTCA, I'm sorry, but it is, in fact, what happens at our institution every day. And also, in doing this, I hope I do not sound like I'm disparaging the care that's delivered in rural America or rural Georgia. It is not. It is only the fact that there are real problems, real shortages in care delivery there that we could hopefully help. So where are we different, or what can we do to help? Well, first of all, cancer these days is an incredibly complex and yet nuanced disease. Every day there are new treatments coming out. It seems almost monthly there are new targeted agents that are being approved by the FDA. And because of that, you need specialists who know all these things, know all the interactions of the drugs, the side effects, and the proper uses of them. It also is being very personal, not only personal meaning the choice that the patient can make, but personal meaning our treatments now are down to the person's or their tumor's DNA. And so, again, highly specialized, very complex, and you need the knowledge of how to navigate through all of that. But I would also add one more thing to this. It's also multidisciplinary. It means that that treatment of cancer these days is just not one modality. It's multiple modalities, not only just surgery, medical oncology, radiation oncology, but also all the integrative care, nutrition, physical therapy, pastoral care. All of that needs to be easily delivered to the cancer patient. Care needs to be coordinated and efficient. At Cancer Treatment Centers of America, we are very geared towards this. As you know, 65% of our patients currently have to come from out of state, and because of that, we are well geared up to and well equipped to accommodate patients who travel from great distance. And because of that, our model of care is entirely based around that. We have a very efficient way of delivering treatment plans. In fact, we can usually have the patients see all specialists and have a treatment plan developed and delivered within 2 to 3 days. We also have a care management and patient navigation model that is well suited towards patients coming from great distance. Constant communication, constant monitoring of how their progress and their journey is going throughout their time being treated. Value of specialty care. We are a cancer-focused hospital. We have developed disease centers in which thought leaders and experts in different cancer types reside. And because of that, a patient who comes to that center has the best experts, the most current knowledge, the most current clinical trials available for the treatment of that cancer. Also, along the same lines, because we are focused entirely on cancer, we are not a general hospital per se, in that we aren't planning to hold on to your patient to treat their cardiac disease or their diabetes or their pulmonary disease. we are more than willing to pass that off again to the practitioner out in the community so that they don't lose their patients to us. And once their episode of care for cancer has been delivered, we are more than happy to get them back to their communities where they belong. Urgency, as you all can imagine, when a patient is diagnosed with cancer, first thing on their mind is how soon can I get this taken care of? And again, we are well equipped for dealing with situations such as that. I think the thing that differentiates cancer treatment centers from most other hospitals is our speed to care. We can usually, because we're all co-located in the same building, we all communicate readily and easily between one another. We can get things done so quickly. Within, like I said before, treatment plans done within a couple days or 3 days. And finally, we have the clinical talent, the resources, the technology, all there, and we can avail all of those to the patients in the rural community if we had more access to them. And I think one thing of which I'm most particularly proud as far as innovation is that at our hospital, as a surgical oncologist, a cancer surgeon, we've developed a very robust enhanced recovery program. That's where it's a multidisciplinary program in which patients are treated on protocols both preoperatively, intraoperatively, and postoperatively, all in an effort to get them home quicker and to reduce the number of complications. And we have published several papers showing not only reduced length of stay across multiple different tumor types, so again, getting patients out of the hospital back to their communities faster, but also very recently showing a significant 70% reduction in opioid use in the postoperative period. And in fact, we just published today was a report and an opinion piece by 2 of our practitioners regarding the opioid crisis. And that is something that is a significant issue in rural communities.
Thank you, Dr. Honda. So there you go. The third question, what's the impact in rural and urban Georgia? The first thing I want to establish is, and I know I'm running into lunch here, so I'm going to try to speed it up. It's been said many times as CTCA has been pushing this through the, there we go, through the legislature, that we're going to put rural hospitals out of business if we pass this law. Well, this chart is a snapshot of calendar year 16. We went and looked at the hospitals that are included in the tax credit program and the hospitals that are included, the communities that are included in that program and in the rural stabilization program, and looked at the numbers that we have seen compared to what the big 5 hospitals in Atlanta have seen. You can see we have seen 63 patients in calendar year 16 from Georgia, from those communities. We're not hurting those communities and those hospitals. It's the migration into Atlanta that may be hurting them even more so. So, just so we can all get to lunch, this is how we see how we can positively impact the marketplace and in South Georgia. So the first one is more prevention and screenings. Under the restrictions, we've kind of been limited on the number of screenings that we can do around the state because of they possibly count towards the ratio. This would free us up to do more screenings with rural nonprofit organizations, with rural employers, with rural churches. We actually have a program called Our Journey of Hope, where we train pastors and lay leaders on how to work with members of their congregation and their families that have cancer. We want to take that more across the state. And finally, we want to work with the Georgia firefighters. You all in your wisdom have passed legislation to create greater access for firefighters to receive cancer care. We have met with the Georgia Fire Chiefs Association and the Georgia firefighters, and they have endorsed our recommendations that we're presenting to you today. They support that because they recognize access is full access, and that's what they need. We want to be able to use the partnerships and collaboration that we have. We currently have students from Mercer University, coming through. We have students from Morehouse that are training at our facility. And isn't it ironic that these docs are being trained to go out into rural Georgia, but yet they may not be able to refer the patient back to one of the places they trained because of the limitations. We think that is significant. We want to help train these doctors to be out in rural Georgia so that they can have earlier detection, greater diagnosis, treatment, and survivorship. As Dr. Yahanda referenced, changes in oncology care happen every single day. PCPs have a hard time keeping up with that. We want to help them be able to do that. We have a new program called CTCA Anywhere. It's a telehealth program that works with our patients and with physicians that we can co-manage those patients out in the rural parts of the state.
Let me just jump in here about the CTC Anywhere telehealth. One of the areas where we're using it most frequently is in post-operative follow-ups. So patients who have had their operation have gone home to their communities, and we go via telehealth to do their post-operative follow-up. So that saves them the journey in the immediate post-operative period when they're still maybe hurting and sore, saves them the journey many miles into our hospitals. So again, care at home where it's best.
The next slide is really about urban Georgia. Some of the same elements we just described will be available in urban Georgia as well, but obviously greater choice and access, increased competition, and enhanced innovation. It's not lost on us that since CTCA has been in the state that you've noticed a lot of the big hospitals in Atlanta have upgraded their cancer centers. They've added new cancer centers. That's what competition and innovation helps to do. This slide just simply reflects the will of the general population in Georgia. You can see 93% support limiting choice. Oh, I'm sorry.
Too far.
I went too far. So now you can see it. Sorry. All right. And I'm running behind time here, so you can see the general public supports what we're trying to do. And since you've seen this already, this is Pam Alford. She's with her family. She's the outcome that we should want out of this whole exercise, because the healthcare delivery system in Georgia should be about outcomes. And here is Pam Alford. She's surviving, she's thriving, because she finally got to CTCA, got the care she needed. Every cancer patient, excuse me, in Georgia deserves the same thing. Thank you, Mr. Chairman.
Thank you.
Hospitals that you have in other states?
It's variable. As you may know, we've got a total of 5 hospitals: Philadelphia, outside of Chicago, Tulsa, Phoenix, and then Atlanta or Noonan. It's variable, but most of them are under 100 beds, but most of them are about similar size to us, so around 50 beds or so. So our largest is in Chicago, and they've got over 100 beds.
Okay. Questions? Okay, Don?
Thank you, Chairman. I wanted to ask, first of all, I want to thank you for being here and thank you for what you do. Cancer is obviously it's a very important topic and issue. I'm a cancer survivor myself, so I have some familiarity with it. And the presentation, I tell you what, when I see you guys, though, I got to think of what President Trump said about the Canadians. You're smooth, really smooth.
Thank you, I guess.
Was that a compliment?
Yeah.
I'm not sure.
Yeah, I'm not sure.
Thank you.
Don't necessarily take it that way.
Yeah.
I got questions, but I'm just going to ask you the one. And one of the last things you said was about telehealth, and this is just kind of a specific. When you said post-operative follow-up, and I guess I'm getting a little telehealth. The word is used, no real good definition of it. It's being used in such a broad sense. And here again, part of you guys with your videos and all that, what exactly do you mean when you say telehealth post-operative follow-up?
All right, so the patient has gone home from the hospital and they're at home. You ordinarily, for most of us, and certainly for me, my usual routine for post-operative follow-up is that they would come back to the office after they've been discharged at either 7-10 days post-operative to have their first visit.
Right.
Well, if our patients are coming from some distance, it seems a bit cruel to have them have to get into a car and travel hours back to our center after having had a recent big operation, when we could try to spare them that by doing this encounter via telehealth. So we will meet in the telehealth virtual room. I'll discuss their postoperative recovery, their symptoms, and even be able to evaluate their wound via telehealth.
Okay, so in other words, for this, and it's good that you're doing it, not taking anything away from it, but really, it's kind of like FaceTime. I mean, you're not really, it's not.
Right.
It's
Right.
It's something that sounds better than what it really is.
Right.
Okay, thank you.
Thank you.
I've got a question.
Joe, did you have a question?
I've got
All
a
right,
question,
Penny.
Jay.
Penny?
You mentioned that of the hospitals that were participating in the rural hospitals, the tax credit program, that you'd send 63 patients, is that right?
63 patients from the counties that, and communities that are participating in the tax credit program and in the rural hospital stabilization.
How many of those patients were indigent?
That's a good question. I don't know the answer. I'll have to get that one for you.
Okay, and how much you said y'all did research, what's your budget in Georgia on research? How much do you spend on research in Georgia?
I do not know that right offhand, but we can get that for you.
And one thing that I couldn't understand, just as a layperson, if you knew the rules when you came here, why do you keep on advertising in Georgia for I guess you call customers, when you know you can't take them?
Well, you have to also understand that we are a 5-hospital enterprise, and most of that advertising is a national advertising. So it's not that we have bought specifically time in Georgia. It is a national campaign.
I live in rural Georgia, and I don't see that advertisement on the Tallahassee station. Like, we look at Tallahassee TV, in Jacksonville, like I do in Atlanta.
Again,
I just.
Yeah, and I don't think we're any different than any other hospital system or health system that advertises in the marketplace. I mean, everyone does it now.
If I couldn't take them, I certainly wouldn't be spending money on advertising if I couldn't have them as customers.
Well, the fact of the matter is, we don't know if we can take them or not, right? Because we're trying to follow the ratio. But one of the things the advertisement does is it creates awareness about cancer care, and that's how some people learn is through the awareness through the commercials.
And I really don't have a problem with y'all, but I think all hospitals ought to be treated the same, and I don't see why y'all should be granted an exception when Legacy wasn't. I don't understand. Let's treat everybody just alike.
We absolutely agree. We would love to be like every other hospital and not have the restrictions that we have.
But you know what I meant, if anybody else wanted to come, let them come.
Okay, Penny, that's more than one question. Ron?
He's got a question. Ron, come on.
Mine's just more of a statement. I hope you'll go back and thank Mr. Stevens, Mr. Mayo, and the rest of the crowd. That was a real bloodbath whenever we got this thing down. It took 2 years, if I recall correctly, to get it done. But just thank those guys for their tenacity to be willing to come in and invest the kind of dollars, which was rather huge, in the state whenever it appeared that we didn't want you.
Thank you. Appreciate that.
And I love lunch, so this is going to be short. We've had discussions because I've had a couple of these bills in committee and we've looked at it, and one of the things that I've consistently said is don't ask our members, because you know how hotly contentious this kind of debate is.
Yes.
Don't ask our members to fall on their sword if we're not going to get any movement in the Senate. We've talked about that for several years. I just want you to know I got your backs.
Good point, good point.
And so, are you going to ever start one of these bills in the Senate?
Well, sir, we certainly plan to work with the Senate CON Study Committee that begins on October the 1st.
And I just want the members of the committee to understand that, so thank you.
Yes, sir.
Thank you.
Patty?
Thank you, Mr. Chairman, and thank you for your presentation. Really good, interesting information. But as I listen to you talk about rural Georgia, and I think about my district, a scenario for you. Someone from my district, stage 4 cancer, Medicaid recipient, contacts Cancer Treatment Center, senior commercial, want to get care from you, but you tell them you met your ratio. How would they really know that's an accurate statement?
You would just have to rely or trust our morality, our truthfulness, because we don't shade it like that at all. And that if we say that we're at the 35% limit, it is because we truly are. And it does not matter to us whether that is a Medicaid patient or a Medicare patient.
Dominic, the last question.
Okay, you mentioned, thank you for your presentation. You mentioned the percentage of indigent care, was it 3%, and you would consider or be amenable to a 5%?
Yeah, we would, yes, sir, we'd be
Now,
amenable to moving to 5.
I know that Legacy had mentioned having conversations with a number of other hospitals and groups to get their feedback. Have you done something similar to that? And do the ones who may be in opposition to this, would they be happy with you only going to 5%, or would they prefer you be at 20%?
Well, I have, I've tried to meet, and as I stated earlier, we've tried to meet with hospitals. I've met several occasions with the hospital, Georgia Hospital Association, and in all frankness, they don't really want to talk to us. One of the things we hope is our desire is through this process is these barriers break down and these walls break down, and that we can meet and talk about how we can collaborate together, particularly with small rural hospitals in South Georgia and in North Georgia that maybe aren't affiliated. We would love to be able to talk to them and work with them. And you know, we're probably never going to meet a 20% indigent and charity care because we don't have an emergency room and we only treat cancer patients. But we're amenable to certainly moving that up to try to further the needs of the indigent and charity care folks.
All right, I know I said one last question from Dominic, but Rick had one. I'm going to let him ask it.
Thank you, Mr. Chairman. We're on this side of the room. Early in the slides, you showed a slide that something you wanted was a change in the definition, that you would want to be a general hospital that did cancer treatment. So does that mean you wouldn't have an ER, or you would do other things? Or, I mean, of course I don't know the definition, but
sure,
you know, from what you're doing, what's the advantage for that change?
Well, it takes away those limitations that are in a destination cancer hospital definition. We are a licensed general hospital already. But our mission, our vision, our values are not going to change. We're a cancer hospital. That's what we'll continue to do. Just by being a general hospital, that's how we operate in every other state. And again, that's what our desire is to do here.
Okay.
Okay, that's it. We are adjourned until 1:15.